A very good evening, everyone. I'm Dr. Deepika from the medical team at BSV, and I'm delighted to welcome you all to Perfection Fortisphere by ISAR Symposium 10.0. Kindly note that today's session provides a certificate of attendance, so we encourage you to stay with us throughout the program. Today's discussion will focus on a very important and interesting ART mixed bag covering gynecological ultrasonography and ART laws. We look forward to an engaging, insightful discussion with our distinguished faculty and expert guests today. To set the tone, it's my pleasure to introduce our convener, Dr. Monica Singh Ma'am, a trailblazer in the field of reproductive medicine. Ma'am is MD DNB with fellowships in minimal access surgery and also of the Indian College of Obstetricians and Gynecologists. She currently serves as President elect Bhopal Obstetric and Gynecological Society, Founder President ISOPA Bhopal Chapter, National Executive Member ISAR. She is also the convener behind several impactful academic initiatives, including the ISAR Perfection Series, the Foxy Symbiosis Series, and the Synergy Academic Club. We welcome you, ma'am. Over to you.
Thank you, Deepika. Thank you, Team BSV, and thank you, ISAR, for this opportunity to host the biggest series of webinars from Indian Society of Assisted Reproduction. Started way back in 2023 after ISAR 27th annual ISAR Bhopal. So this series has already completed 15 episodes last time, and today we are on the 10th episode, so that makes it a total of 25. And we would definitely like to continue the series in the next incoming presidential year. But as all good things must come to an end, so today we come to the end of the Perfection Fortisphere Scientific Symposia, and this has been a tremendous journey where we have covered a lot of topics related to embryology as well as the clinical aspects of assisted reproductive techniques. So, since we were falling short of topics and there were some topics in very high demand like ultrasound, imaging, ART bank, and surrogacy. So, this time, the last two episodes, we went to a mixed bag type of program in which we have multiple topics. So today we are very honored to have amongst us our dignitaries of ISAR, President Dr. Amit Patki sir, Secretary General ISAR Dr. Asha Bakshi ma'am. Our chief guest of the evening is immediate past President Foxy and President-elect of ISAR Dr. Sunita Tandulwadkar madam. Our special guests for the evening are Dr. Basav Mukherjee, National Coordinator Foxy and past President of Bengal Obsgyne Society, and Dr. Varsha Baste madam, past Vice President of Foxy. We have our guest of honor, our very energetic and dynamic Secretary General of ISAR, Dr. Asha Bakshi madam from Indore. My co-convener is Dr. Randhir Singh, and today on the 19th of January 2026, we are very glad to present before you the 10.0 Mixed Bag Symposium of ART. I'll just walk you through the program before we begin the formal introductions. From 5:30 to 6 p.m., we will be going through nuances of imaging in the infertility patient. Not all gynec sonologists or those who are ART practitioners are necessarily very good ultrasound specialists, but they should know enough of every pathology and parts of anatomy which are important not to miss any significant diagnosis in a patient who is subfertile. To take us through this journey, we have Dr. Asha Jain, who is also the chairperson of the Food, Drugs and Medico-Surgical Equipment Committee of Foxy. Her talk will be chaired by Dr. Gurneesh Singh from Hisar, myself, and Dr. Mitsu Doshi from Surat. From 6 to 6:30 p.m., Dr. Archana Baser will be deliberating on its stepwise approach to imaging in endometriosis. Madam has been the past chairperson of Imaging Committee of Foxy as well as Vice President of Foxy, and she is very keen ultrasound teacher as well as practitioner. Her session will be chaired by Dr. Anu Agarwal from Varanasi, Dr. Praful Doshi from Surat, and Dr. Sudhir Adhikari sir from Kolkata. From 6:50 to from the last session is actually only 6:30 to 7. There's a typo mistake here. We will be studying the nuances of the new ART Act, and how can we overcome challenges as gynecologists, especially those who are contemplating setting up level 1 and level 2 ART centers or associating themselves with ART banks and surrogacy. So, Dr. Randhir Singh, my co convenor and managing committee member of ISAR, will be talking about this topic. His talk will be chaired by Dr. Sushma S. Deshmukh, past president Nagpur Obsgynae Society, herself a very able IVF practitioner, Dr. Palak Gauri from Raipur, and Dr. Lavanya Tyagi, our new budding gynec and ART specialist from Lucknow. So, we now go on to our formal introductions and we will introduce the dignitaries as they come. Dr. Amit sir is yet to join. Dr. Bakshi ma'am is joining very shortly. So, we move on to chief guest has not joined till now. Madam, we are waiting for her also.
Dr. Monica, Dr. Sunita madam is operating, so as soon as she will free, she'll join.
Okay, okay. So we have amongst us a special guest for the evening. So I've been often asked in my programs that, Monica, why do you have special guests? The special guests are those people who are very special. They hold a special, role not only as guests for the evening, but somebody who are very special to our journey as gynecologists, whether we have worked in Foxy or in ISAR or in any other conference, they hold a special place in our hearts. So we have Dr. Basam Mukherjee with us and Dr. Varsha Baste. I would like to formally introduce our special guests. Dr.
Monica, I think
Basam,
let Dr. Varsha go first. Dr. Varsha is
yes,
sitting
yes.
here. I would like Dr. Varsha to go first. Yeah.
Dr. Varsha Baste, please. Dr. Varsha Baste is someone who is looked upon as a senior and a mentor and a very loving leader by all Foxians. So I have seen her working for the last 25 years. I have seen her personally. I have been in her home, in her heart, traveled with her, talked to her, interacted with her, and definitely she has given us very good academic platforms. And recently we were in Nasik to attend the VPCon hosted by Dr. Varsha Baste madam. She was the immediate past vice president of Foxy, who led Foxy brilliantly the past year with Dr. Sunita Tandulwadkar madam as president Foxy. She is the awardee of Dr. Anandi Bai Joshi Award, a MOGS V for Stree Puraskar by Honorable Governor of Maharashtra, Foxy Champions of Foxy Award, and Foxy Excellence Award for the outgoing Foxy chairperson. She is also credited with the first ICSI and PGD baby of Northern Maharashtra in 2003 when we were all just struggling to establish our IVF centers. That time she had already delivered the PGD baby. She has held several administrative key posts in the OBGY Society of Nasik as well as in MSR, Maharashtra ISAR, and of course is a great teacher and an exemplary human being. Madam, the stage is all yours.
Thank you so much, Dr. Monica Singh, Monica darling. The name of Ranbir and Monica is synonymous not only in ISAR but also in Eshre, because I have seen them presenting papers in each and every Eshre, and they have really held the flag of ISAR very high in Eshre and all conferences. I'm really fortunate and I'm feeling uplifted with the name of special guest, another name, Dr. Basad Mukherjee. He is also a very well-known person, great human from West Bengal. And the chief guest of honor, Asha Bakshi, and all the stalwart, Amit Patpi, Dr. Smita Tanvarkar. I am feeling really flattering with all these photographs, my photograph with all, along with them. Dr. Monica and Dr. Ravi Singh, you really are passionate learners and teachers and research oriented. And that is what I have come across you from since long. You really like to go into deep in the subject and present really unknown subjects you have touched and presented your papers, and so much of huge data you have presented from the Indian side in ISAR and also in Eshre. I'm really grateful for you give me opportunity to this witness this platform. The stalwarts are I'm not going to repeat, but the stalwarts who are going to give these deliberations are really perfectly chosen by you and perfect for the imaging and the RT Act law and whatnot. It is really a conglomeration of your brain and your knowledge and your updates what is to be presented and what is to the audience, and it is a need of time, and the upgradation and the revision of these subjects are already always needed with newer updates. I congratulate all the co-conveners and coordinators and all these stalwarts chairpersons. Thank you so much for inviting me, and over to you again, Dr. Monica, and I wish you and Ranveer all the best for your future endeavors. You will definitely shine in ISAR and take it as a torchbearer to Asia 2 and all over India. Thank you.
Thank
Thank
you.
you, Varsha ma'am. Thank you, ma'am.
Thank you, Varsha ma'am, for the kind words. And we are definitely not worth what you have made us, but we are just small workers of ISAR, and that is what we want to be always. So now I welcome, before going to Dr. Formal introduction and welcome of Basab sir, I extend my good evening to Asha Bakshi ma'am, who has just joined us from Indore. Good evening, ma'am.
Good
Now,
evening.
yes, ma'am. And it's my great pleasure to extend a very warm welcome to Dr. Basam Mukherjee, sir. Dr. Basam Mukherjee, sir, is said to be the right hand of our president, Dr. Bhaskar Pal. So whoever wants to have good, entry into Foxy can be, constant touch with Basab sir. But sir, that was not my intention when I invited you, because I invited you because you are always a very dignified person to be in the program, and
Thank you so much. So kind of you.
you raise the scale of the program very high, sir. And your picture on the flyer is something which is, oh, Basab sir is going to be there, so he's going to definitely give us some good inputs. So we have seen you organizing conferences. We've seen the strong and silent Dr. Mukherjee, in the flagship roles. Of course, you have been a brilliant vice president, FIGO regional coordinator, regional secretary of IRC India East, president of Bengal Obsgyne Society, and also led the Kolkata Menopause Society and the IAGE chapter of Bengal. We know
I
all
will
of your,
call, sorry,
and we
I will.
know, yes, sir, yes, madam.
I will just, I'm sorry for interrupting, but what came into my idea, Dr. Bhaskar Pal is a tiger of Bengal and Dr. Basa Mukherjee is a cub of Bengal. Tiger.
No, no. I think he is also a second tiger, Varsha ma'am. So we
Tiger.
have now stalwarts coming from the eastern part of India, and everybody vouches by the intellect. I also had several Bengali friends in my school and in my boarding. So I don't know what, but there is an intellectual level which is given to them, which is, much above everyone else. They think out of the box. They think something which is very different, and they think brilliantly. So, sir, over to you, sir Basab, sir.
Thank you.
We are honored to have you in our program.
Thank you, dear Monica. Thank you. Thank you, Randhir. Actually, don't exactly fit in this. ISAR is not what I have done over years. So this is a little new. Foxy has been our fort. But yes, it's always a pleasure to be around. The ISAR crowd is a much more joyous and much more playful crowd compared to the Foxy crowd, which is more serious. Whatever little bit I've attended of the Ashrays, and I've understood that the ISAR crowd is a much more jovial and much more connected crowd than the Foxy crowd. So all the best to both of you in your ISAR roles. And this program, I think from the time of COVID, we've understood that all academia should be a balance of physical and webinars. Webinars would essentially be for people who are really interested in learning, who do not travel much, and who have an option of putting their phones on and just listening passively to get some information which is generated by the quality faculty, which here you have put together. So Dr. Asha Jain, Dr. Randhir, and Dr. Archana Baser over the next hour, couple of an hour and a half would definitely have good deliberations, which most of the attendees would benefit from. I'm sure you're recording these programs, Monica, so that people later you can archive them, and later you can also the quality of academia can be utilized for people who want to hear it later. Dr. Asha Bakshi, welcome. Thank you for joining. Dr. Asha Bakshi is an inspiration to all of us. She is a star in her own rights, star, superstar, whatever you call her, in RCOG, in Foxy, in ISAR. You can see her again, you can say silent champion. She is the silent champion, actually, more than a lot of us. And thank you, Dr. Asha. Again, you're a very inspiring person for all of us. We don't always say it, we don't always spell it out, but this is a chance that I'm also getting to appreciate your presence here. Thank you very much for inviting me. It's an absolute pleasure. By 5:30, we should wind up all the intros so we can start the actual academic program. Yeah. Thank you. Thank you.
Thank you, sir. Thank you, sir. And
Thank you, Basab sir. And I remember, Monica, it was 23, sir. My SAR conference was just a few weeks before, and in AICOG Kolkata, you gave me the platform to just announce my conference, and it was a super hit. Bhaskar sir also came. So thanks, Bhaskar. Thanks, sir.
Thank you. Thank you, Randir.
thank you, Basib, sir. And now I welcome Dr. Asha Bakshi amongst us, our guest of honor and also Secretary General of ISAR. Madam is contesting election for second vice president, and we give our best wishes to Madam from our team for her endeavors. She is a leader par excellence. She is. We have known how she has led Madhya Pradesh in all the organizations and committees she has been in. She is very encouraging to juniors, always lends a helping shoulder to whoever needs her. She has been an exemplary figure in the city of Indore and has taken Indore to the level of even it is called a mini Bombay, with numerous awards and papers to her credits. Organizer and organizing chairperson of multiple successful conferences, including the recently concluded AICOG 2022. And Indore will be soon hosting the next national ISAR. So, Madam, welcome. And we would like to have words of blessings from you, Madam.
Thank you very much, Monica, for the kind words. And first of all, my warm regards to Dr. Amit Patki, Dr. Sunita Tandulwarkar. I don't see them here, but I'm sure they were here. And because I joined late, so I don't know. But and my warm regards to Dr. Basav Mukherjee and Dr. Varsha Baste, who are the special guests. And Basav, in Calcutta, is it very cold? How come you are wearing a jacket?
Yeah, still just it's means it's Delhi leftover. So maybe it's nothing compared to Delhi. It's 5 degrees more than Delhi's, but
Yeah, because
nothing,
Indore is not cold at all. And when I saw that, I thought, is it cold in
not
Calcutta?
not that cold. I'm just putting on something just
So, Dr. Varsha Baste, we all know she's a all-rounder. She's not only a good leader, but she is good academician, a good clinician, and at the same time, she has knowledge about so many things. Cosmetics, you talk to her about cosmetics, you talk to her about weight, and her language. When you read what she writes, is really amazing. I feel from where she gets all these good phrases. And so is Basav. Basav, I'm mad. Means I'm so impressed by the way you describe the things, and you are too good. Especially when you used to read your VP reports, I used to always think that I should copy him how he does that. So it's so nice to have you both here. And again, I would like to thank Monica and Randeep. Monica, all the best for your endeavor in ISAR. So for the Randir, I'm sure you both are going to win with a good margin. And I'm thankful to Garima, to Manisha, to Neelam, Ankita, Payal, and Purva for so sincerely conducting, coordinating these webinars. And they are so important and so popular. That's most important. And the topics are so focused. And today you have really selected very good speakers, Dr. Asha from Raipur, Dr. Archana Basir, and Dr. Randir. And the topics, ultrasound, I think there can not be, I feel these days there cannot be a gynecologist who
can work without ultrasound machine. I cannot imagine any clinician without the knowledge of ultrasound. So it's a basic thing, and I think we all should be sensitized to it as much as possible. And about endometriosis, if you are really good in the transvaginal ultrasound, there is no need of MRI also for endometriosis, because in MRI also it is the man behind the machine who reads, and so many times, unless you really tell to that person, please check for the nodules, please check for this, please check, they also miss. So I think we are the best. So if we are very good in doing good transvaginal ultrasound, demonstrating all the sliding signs and whether the pouch of Douglas is obliterated, how is the bowel, what are the nodules, all these things are very, very important. And I'm sure you will learn all these things today. And I think who else can be better in talking about ART law than Randir. Whenever I feel that there is a problem, I would like to ring up Randir and ask him what to do in such a situation. So we will learn a lot. Hi, Anu, welcome. Hi, Dr. Gurmeet Singh. Welcome you to you all. So I would like, I wouldn't want to waste any more time, and please go ahead with your academics and all the best. Hi, Asha. So, right.
Thank
Thank
you.
you, ma'am. Thank you, Asha, ma'am. Thank you.
Thank you. Thank
The
you.
blessings are very, very precious to us, ma'am. And now, just a word about my co-convener is Dr. Randhir Singh. Both of us are managing committee members of ISAR. And my co-conveners are Dr. Garima Sharma from Mumbai, Dr. Manisha Bajpai from Udaipur, and Dr. Neelam Bissev from Mumbai. All are managing committee members of ISAR. And my coordinators are Dr. Ankita Upadhyay, who is Associate Professor at Chirayu Medical College, Bhopal, Dr. Payal Raghuvanshi, who is a fertility specialist in Bhopal, and Dr. Purva Bhatkur, who is Associate Professor in Gandhi Medical College, Bhopal, who work very hard in order to get this program together. Thanks to all of them. Now I hand over the first session to Dr. Purva to start the session number 1.
Thank you so much, ma'am. So moving to our first session, that is nuances of imaging in infertility patient, we invite Dr. Asha Jain ma'am to deliver the talk. To chair the session, we have Dr. Gurneesh Singh sir, Dr. Monica Singh ma'am, and Dr. Mitsu Joshi madam. Dr. Gurneesh Singh sir is Medical Directorate and Senior Consultant, Elora Eve Care Hospital IVF Center. He is presently President of Hisar OBGY Society, President IMA Hisar, and former Professor and Head of the Department, Maharaja Agrisen Medical College, Agroha. We welcome you, sir, to chair this session. Next, we have our own Dr. Monica Singh, ma'am. Madam is presently President-elect of Bhopal OBGY Society, Founder President ISOPAP Chapter Bhopal, National Executive Member ISAR. We welcome you, ma'am, to chair the session.
Thank you. Thank you.
Next, we have Dr. Mitsu Doshi, madam. Madam is a well-known obstetrician, gynecologist, IVF specialist at Me and Mommy Hospital, Hospital and Blossom IVF Center in Surat. She has a vast
So I think Purva is having some network issues. Dr. Gurneesh, you can start introducing our speaker. Anmol, please give us the CV of our speaker, madam. Thank you, Purva. We will start introductions.
I am grateful to Dr. Monica for making me part of this webinar. And as far as our speaker, Dr. Asha Syed is concerned, I have known her from webinar for last 1 year. She's a wonderful person. And in this IICOG, I had fortunate enough to meet her. She is Director, SMSA Hospital, Jaipur, Medical Director, Cancer Prevention Relief Society, elected member, CG Medical Council.
Sir, I think that's enough. You can just introduce the topic.
Yes, ma'am. Madam will be speaking on the nuisance of the ultrasound in infertility, which is also very close to me because when I was in second year in FMC, they put ultrasound machine in my room only. From that day onwards, for almost more than 20 years, I'm doing ultrasounds. And whenever I made mistakes, there were people to correct me. And without saying further, I will request Dr. Asha to please take over now.
Thank you, sir. And I hope I'm going to do justice to the program because I am not an IVF person. Yes, I do treat infertility and I've been doing ultrasound for very many years. So as is usual for me, Shri Ganeshaya Namah, we start the program with blessings that our intellect may work correctly. And the topic that Monica has given me is nuances of imaging. So I'm not going to talk about the basics. It's only about the finer points and a final put together that I have to speak about, and I have about half an hour. So why do nuances matter? The thing is, most infertility imaging errors are not clinical. They are not technical. They are the timing, interpretation, and reporting gaps. Because Asha Bakshi ma'am said that a gynecologist should be doing scans, but it is still a truth that more than 80% of our gynecologists are not doing the scans themselves. Sometimes they are not done at their center also. The patient goes and gets the scan done. And there is a disparity. Timing, interpretation, and reporting is where the problems are. A gynec scan, the same scan, but a different day of the cycle, will have a different diagnosis. Whether it is a follicle versus a cyst, a polyp versus an endometrial fold, a contraction versus septum. So, imaging must answer clinical questions, not just normal, abnormal, because everything is relative. So, what is the aim? The aim is to reduce unnecessary invasive tests and also fast track the correct treatment. Supposing a polyp is reported in the late luteal phase, when you do a early follicular saline infusion sonography, there's no polyp. On a 2D scan, a septum is reported, which is actually a contraction. And when you repeat the scan after some time, you find that there's nothing there and surgery is avoided. So, this is the fertility and sterility ASRM November 2021. They have given guidelines what to do for investigation of infertility. So, where do we use ultrasound? We use ultrasound for transvaginal ultrasound to detect ovulation. We do it for ovarian reserve. Then we do it a transvaginal sonography, a saline infusion sonography, hysterosalpingography, hysterosalpingogram, hysterosalpingo contrast sonography for the shape of the uterus, the patency of the tubes. So this is where we need ultrasound. Imaging complements the history, the exam, the ovulation assessment, the semen analysis. The imaging goals are in the ovaries to see the reserve markers and morphology, in the uterus, the myometrium cavity, in the tubes, the patency and hydrosalpinx, endometriosis mapping, especially deep disease, also adenomyosis, fibroids, choose test based on pre-test probability and the next clinical decision. It's not that you have a list and you do everything for everyone. Imaging is a decision tool. So if you have a report, you should know what you're going to do differently based on the report. So you need to give clear guidelines about what you want in that report. What is the practical imaging algorithm? Step 1 is the baseline transvaginal ultrasound, cycle day 2 to 5, where you're going to see the uterus, the myometrium, the cavity, then the ovaries, AFC and CIS, the adnexa. Step 2, if there is a suspicion about the cavity, if there's a history of failed IUI, IVF, repeated pregnancy losses, or abnormal bleeding, then you would do a saline infusion sonography or an SHD plus a 3D ultrasound. And in a 3D, you are going to be able to see the entire cavity in a beautiful way. Step 3, if tubal factor is suspected or there is unexplained infertility, you would do HSG or do a HICO-C or a contrast sonography. It's very, very beautiful and you can actually see almost everything there. If endometriosis symptoms are there or there is a prior surgery, you would have to do a targeted ultrasound. You need to do a mapping. And supposing you're not able to understand it properly because of adhesions, because of a lot of shadowing, then you consider MRI. Don't overtest. The most important thing is to do the baseline transvaginal ultrasound well. Because if that is not done properly, then all your interpretations are going to change. In infertility, timing is a diagnostic tool. Writing the LMP, writing the day of the cycle is a diagnostic tool. So best window for baseline infertility is day 2 to 5. For the cavity, you need an early proliferative phase where the endometrium is thin. The common false positives in the luteal phase, you have polyps, transient myometrial contractions, septum or adenomyosis is reported. Hemorrhagic corpus luteum is reported as a solid ovarian lesion. So in the report, the cycle day, the LMP, and if the patient is taking any kind of hormonal medications, it has to be mentioned. So in every report, there should be a standard line, cycle day, LMP, and whether any hormones are being taken, and if yes, then which hormones. That has to be noted. So what about the minimum data set for transvaginal ultrasound? Infertility report. This is the guidelines by ISWAG. The report must include in the uterus the position, the size, the myometrium, mention if there are any features of adenomyosis or fibroids, and FIGO location if possible. Also mention the cervix. In the endometrium, the thickness. If there is any fluid, then you have to measure two layers, the double layers separately. The pattern of the endometrium, any focal lesion, and vascularity when relevant. In the ovaries, the volume, the antral follicle count, the dominant follicle cyst details or endometrioma features. In the adnexa, hydrosalpinx, adhesions, tenderness with probe. Now, when you're doing an ultrasound, it is an extension to your fingers. So, tenderness you can note down, and when you make the report immediately, you should definitely write that there is tenderness. Then there is a sliding sign. What is a sliding sign? When you put in the probe, the tissues moving against each other rather than adherent. That is the sliding sign. And if it is absent, then endometriosis is suspected. If there is free fluid, what is the amount? Where is it located? And what is its character? Is it hemorrhagic? Is it plain blood? Is it just watery? You will be able to make that out by looking at it. And then there should be a clear impression. What does it mean for fertility or for planning of ART? All these things have to be mentioned in a report. So this you can see here. This is a gynec scan which I did today, and you will see this is the uterus where you have to mention the position, anteverted, anteflexed, measure it in 3 dimensions, see the clear blood supply. When you do a 3D, you see the shape of the cavity, you see the outer margin, you see the tubes. Because she is on her 4th day of period, there was blood, so we could see even the cornual portion of the tubes. And whether the endomyometrial junction is clear. If it is clear, that rules out adenomyosis. And then both the ovaries and presence of any free fluid, what is the character, whether it is anechoic, hyperechoic, hypoechoic. This is what you should be able to see in a baseline scan. Now, this is where you just put in the probe and you can see the movement of tissues against each other, and that is the sliding sign. So if you are able to see the movement, okay, this is the completion of the same scan where you can get the AFC, you can get the volume of the ovaries, you can get the blood supply, the blood flow of the ovaries, and also the the component of stroma in that ovary, along with the uterine blood vessels, the pressure, the PI, the RI. The RI and BFI are important parameters which tell you when ovulation is likely to occur. In the ovary, AFC and reserve, how to be consistent. AFC is operator dependent. We need standardization. So we need to scan in the early follicular phase, antral follicle counts in agreed size and range. Then we have the sono follicle, sono AVC that we do that I have shown there. But again, you cannot leave it on the machine. You have to walk through the entire ovary and see that all the follicles have been counted. What are the pitfalls? Prior oral contraceptive pills or GnRH use suppresses the AFC. Endometriomas can reduce the visible AFC. And so, if that happens, where you're not able to really see the AFC, then you have to write in the report that AFC may be underestimated due to whatever, use of GnRH, use of OCP or endometrioma. That should be mentioned in the report. Otherwise, again, you will not be giving the correct estimation to the clinician. Now, ovarian cysts, when does it matter for infertility? Functional cysts can be simple or hemorrhagic. They are often seen. There can also be residual cysts, and the treatment is not to give any treatment, but to follow them up after 6 weeks, after 3 months at the most, and in 6 weeks they are gone. Endometrioma does affect the ovarian follicle reserve, oocyte yield, and also leads to surgical decisions. So you need to measure the size, you need to document classic features and note bilateral disease. Now, endometrioma, whether they go for surgery or not, that was a major question that I spoke of in AICOG. And there is no improvement of live birth rates if endometrioma is operated. That is as the consensus stands today. When you do a scan, when there is a cyst, it could be a suspicious mass, a solid mass with papillary projections with high vascularity. In that case, you need to escalate it. You need to follow the oncology protocol and do the iota screening and find out not all cysts are endometriosis, and rescan timing will help. So as you can see, these are multiple endometriomas in the same ovary. These are multiple endometriomas, and it is not possible to actually measure the antral follicle count because the ovary is almost replaced by these endometriomas. What about adenomyosis? Small details have a big fertility impact. Adenomyosis is common, it is underreported. We need to use structured features, direct, indirect signs rather than vague language. The key nuance is transient contractions can mimic adenomyosis and anomalies. So you need to reassess after a few minutes, and a cine clip helps. The report should state whether it is focal versus diffuse, junctional versus heterogeneity features, coexisting fibroids or endometriosis, and this is the impression. But what you see, whether you see a rainy forest sign, whether you see vascularity inside, all that has to be mentioned. See this patient. She is an unmarried girl in a relationship. And if you follow closely, you can see there is, both her ovaries are stuck. There is a large endometrioma and the uterus is pushed backwards. Everything is adherent. She has kissing ovaries. Can you make that out?
Yes, madam.
So then there is fibroids. What is the relevance of fibroids? Fertility depends on location, not on the size. Because if it is submucosal, if there is cavity distortion, or there are intramural fibroids. They matter the most. So we need to document what is the size and number, what is the relation to the cavity, whether there is distortion or not, and if there is vascularity and if there is degeneration. Small intramural may still matter in repeated ART. These days, when we are talking about the finer points, the receptors, so and inflammatory signs, then fibroids increase that. This is a patient who came to me and she was told that she has adenomyosis. Would any of you say this is adenomyosis? This is a huge fibroid sitting in the uterine cavity. When you've taken a 3D, you can make out the whole borders. You can see the circular flow around it. So then there is the saline infusion, and you can see how much of the fibroid is inside the cavity, how much is in the wall. It helps in the FIGO staging. Endometrium, the thickness alone is not everything. You need to report the thickness in double layer. What is the pattern? If there are any focal lesions, if there is fluid. If there is fluid in the endometrial cavity, especially before ovum transfer, think hydrosalpinx or endometritis. Avoid overinterpretation. Thin endometrium is context dependent. Cycle day, stimulation, estrogen. If endometrium appears irregular or polypoid, saline infusion sonography in early proliferative phase will give you an answer. So these are the various endometrium stages. This is from the White Journal. Menstruation, follicular phase, ovulation, and then the luteal phase. And you can see the character, the thin endometrium, the triple layer, and then the secretory changes occurring at the edge. And then finally, it's all secretory. If when you do a saline infusion, this is a simple polyp, this is irregularity, and here this is very, very irregular. And when it is irregular, the chances are it would be malignant. What about Doppler? You need to do uterine artery Doppler. High resistant flow may be seen in adenomyosis and fibroids affecting uterine perfusion. It has a limited role in routine infertility evaluation, and no single Doppler cutoff predicts implantation. What about endometrial and subendometrial Doppler? You assess the endometrial vascularity, subendometrial blood flow. Poor vascularity may be seen in thin endometrium and chronic endometrial damage, Asherman syndrome, endometritis, tubercular endometrium. And these are the various types of blood supply that you see in the endometrium. And they each signify something else. So multiple vessels without a pattern are what click your mind that this could be malignant, and you need to note it down even if the patient is coming to you for infertility. This is a 3D of a fibroid which is taken in 2 dimensions in 3D, and you can see that it is inside the cavity. You can measure the size, and you would know that if you've measured the size, how much is inside, whether you can attempt it by a hysteroscope, how much time it would take, how much fluid it would take. That decision can be taken by a 3D ultrasound. And then sometimes the endometrium is thick with a little fluid, where you have to measure both layers separately. About cavity lesions, whether you would do transvaginal ultrasound versus saline infusion versus hysteroscopy. So I would like to tell you that they are just complementary. They are not against each other. Simple transvaginal ultrasound can miss small lesions or mislabel folds as polyps. But when you put in saline, you are able to clearly demarcate polyps, submucosal fibroids, adhesions, and niche issues. So 3D SIS will provide whole cavity reading in one data set, which you can cut in different sections and decide what is wrong with the uterus. What about the congenital uterine anomaly? You need to avoid the common trap. Septate uterus should not be diagnosed casually on a quick 2D scan. It should not. there should always be a 3D transvaginal ultrasound. And if you're not sure, then go ahead with an MRI, because you need to have the fundal contour. In a septate uterus, the fundal contour is normal, it is convex. Then you need to measure the internal indentation and then the shape of the cavity. Overdiagnosis leads to unnecessary hysteroscopic metroplasty with its own problems. So you have the septum length and the septum angle, partial septate. This is a normal uterus. So you can see the top. This is absolutely normal, and this is what we need to know. We need to see the complete integrity, and the 3D scan will give you all this information about all the types of septate uterus. This is a saline infusion 3D scan, and you can see this is an irregular cavity. This is a sign of endometritis. This is a septum, and this is a normal cavity. So very easy. And this also has a polyp here, which you can make out on a saline infusion. And it's absolutely evident. You don't even have to make an effort to do it. What about tube testing? Which one and for whom? HSG is widely available. It's good first line in many settings. But now we have HICOSY and contrast sonography, which is an office ultrasound based option. In saline infusion, spill observation is not enough to label unilateral versus bilateral. So you have to choose based on availability, patient comfort, and how much detail you need. I will show you. This is tubal patency with hyphocy Doppler technique. And here you can you see both the tubes? This is the contrast flow. This is hyphocy in grayscale, and then the 3D rendering. And this is with power Doppler. You can easily make out the entire tube. Now, these are book images. I will show you a video of what I have done, and it will be so very easy for you to make out. Hydrosalpinx on ultrasound, tubular elongated cystic structure, incomplete septi, waist sign, separate ovary. Hydrosalpinx is associated with reduced implantation and live birth. So you need to do a salpingectomy or a proximal occlusion before IVF. We need to know whether it is unilateral, bilateral, what is the size, and whether it is communicating with the uterus. This is a patient, she's an unmarried girl, and she came to me, and in a 3D inversion mode. Can you see both her blocked tubes? Harnish sir? Gurnish sir, can you see? The entire tube inversion mode, it's blocked. So it's a simple, I haven't done anything. It's just an inversion mode 3D, and it has given me this picture. Then we come to the saline infusion. And if you follow carefully, this is the first that we have attempted. And you will see that you can see the ends of the tubes. In the next one, follow the movement and you will see the dye moving. It goes here and it spills. You'll see it's moving, the dye being pushed here. You can see it completely. Both the tubes, the movement of the hypocrisy, and then the spill. Very, very, very easy to see when you're doing it by hypocrisy. And this is the rendered image where you see the entire tube and the spill. So it's easy. It's an OPD procedure. This is endometritis with a lot of irregular endometrium with saline infusion. So imaging is now mapping. It's not just a yes and no. Think in 3 points: ovarian endometrioma, DE, or adhesions and distorted anatomy. A targeted history will help. And ultrasound can guide surgical planning when done systematically. MRI can complement. So if you suspect DE, the right symptoms have to be asked, and accordingly the scanning can be done. So when it is suspected, there is a checklist. Document the ovaries, endometrioma, mobility, kissing ovaries, POD, obliteration of sliding sign, uterosacral ligaments, posterior cervix region, rectovaginal septum, bowel involvement suspicion, bladder and anterior compartment. So if you have this checklist, you would not miss anything just while putting in your probe. Now we come to PCOS. Ovarian morphology alone is not equal to PCOS diagnosis. Report should describe the ovarian volume, follicle distribution pattern, and stromal appearance. This has to be correlated with ovulatory pattern and biochemical features. If the patient is on OCPs, the ovarian morphology changes. So the report should say polycystic ovarian morphology and not polycystic ovarian disease. These are the images. This is the sono AFC you can see. The number of follicles can be counted. The uterus in 2 diameters, then both the ovaries and the sono AVC. When you go to this, you will see this is a patient where the uterus is anteverted retroflexed. It's a corkscrew-like uterus. So even in the most expert hands, you put in your probe and you're not immediately going to see anything. You can follow the endometrium here. See. So you need to have patience. There is free fluid also in this patient. And the most important thing is that it is day 3, but the endometrium is already secretory looking. So it's not a normal endometrium. Ovarian Doppler findings, stromal vascularity is increased, low resistant flow in the ovarian stroma, decreased RI, increased PSV, usually bilateral. So PCOS remains a clinical and biochemical diagnosis. Do not label PCOS based on Doppler alone. Follicular monitoring, interpret in context of stimulation protocol and day of stimulation. Dominant follicle size plus growth trend, endometrium thickness, pattern, fluid, trigger planning, very high follicle count, persistent cyst. So if you are able to interpret it correctly, simple scanning becomes high impact for ART and IUI outcomes. What about Doppler? Follicular Doppler perifollicular flow may indicate follicular maturity. Low resistant flow is seen near ovulation. It can help you understand follicular physiology, and it may also help to explain poor response or LUF suspicion. ART readiness scan, what to check before embryo transfer. In the endometrium, whether there is fluid or focal lesion. In the adnexa, if there is hydrosalpinx or endometrioma. In the cervix, if there is angulation, stenosis, then you need to correlate and find out. Cavity fluid in transfer cycle is not a minor finding. You need to really take care of it. Red flag reporting, what you should avoid. Don't write polyp, septum, PCOS, tube block, PID. You need to describe what you see and describe the next step. You have to do an SIS in case of endometrial lesion. Uterine anomaly 3D, MRI, polycystic ovarian, correlate clinically with biochemistry. Hydrosalpinx features present, then you need to do a tubal patency. So what is the take home? There are 10 practical rules. Always state the cycle day and the medicines being taken. Day 2 to 5 baseline scan is your best friend. If cavity matters, saline infusion sonography or 3D at the right time. Don't casually label septum on 2D. Hydrosalpinx diagnosis changes the IVF plan. Be alert. When D is suspected, scan as mapping. Don't just say yes or no. AFC needs consistency and context. Avoid absolute conclusions when technique limits exist. Impression should link to the next clinical step, and a standardized template improves quality more than fancy machines. You need a standardization. These are the references I have used, ISWOG and ASRM. And this is a one-page infertility imaging report template. That takes the patient's name, age, indication, LMP, cycle day, hormonal treatment, and then the different points about the uterus, endometrium, ovaries, adnexa, and pouch of Douglas, the impression, and the recommended next step. It has to be reported by whom and signed, and then the date. This has to be your basic infertility scan report. This is the citation of the ISWOG that I have taken. It's a 2026, January 26, pre-publishing paper on guidelines for gynec scan. So thank you so much. I hope I have not bored you and we have learned something more together. Thank you.
Thank you, Dr. Asha. As usual, always crisp, always answers, clear answers, no doubtful edges. For last 1 year, whenever I attended, I have learned hell of a lot. But ma'am, just for the people like me who have got 5 minutes maximum to scan and then push patient for next ART. I think
Don't
whenever
need a
you are in
scan,
doubt,
sir. Send to somebody who has time. You cannot do a good scan in less than 20 minutes. You cannot.
just 1 minute, ma'am. For in 2D, whenever you see any abnormal thing, it is better to do 3D. So many things get clarified. Otherwise, you
Sir,
remain
I
doubtful.
would take a 3D initially. In the first 5 minutes, I would take 3D of the uterus and ovaries. Why? Because you have that entire volume of tissue which you can cut at your ease when you have time. You can cut and see. You can walk through the entire specimen. You have the whole data set. So don't think that 3D is something special. My charges for 2D and 3D remain the same because I never do only 2D. I'll always do Doppler, I'll always do 3D. Get it? That volume capture doesn't take any time.
Thank you for the excellent advice, ma'am.
Thank you, sir.
Mitsu ma'am, would you like to give your inputs? Dr. Mitsu Doshi.
Thank you, Asha ma'am, for a wonderful talk highlighting all the nuances of infertility. And you had made it so comprehensive, still detailed, and covered every topic. I think those who have not attended will be missing a lot. Thank you very much. It was wonderful being here. Thank you.
Ma'am.
So,
Thank
Asha
you.
ma'am, I would also like to give my compliments and remarks.
Okay.
I think your slides, I have taken a lot of screenshots which I'll be sharing in the groups. It should be converted into a textbook chapter because they have been made so crisp and compact, like Mitsu madam said, that any postgraduate or radiology resident or OBGY resident or fellow of ART would benefit from going through these without having to go through all the various guidelines and articles. Number one, madam. Number two, ma'am, I really think that like in obstetrics, as per the current legal scenario, you cannot say that in a target, this was the normal scan which I did, a biometry, I have not done a target. This is inexcusable in court nowadays. So every scan should be done in order to visualize all structural anomalies. Similarly with gynec, you cannot avoid doing a color Doppler, putting a power angio where it is required, doing a sliding sign where it is required. Madam, I was quite intrigued by your inversion of the 3D image. So how do you do that?
It's you take a 3D, capture it. See, the important thing about 3D is you cannot take a good 3D unless you have a good 2D image. You cannot have a blurred image and then think that your 3D will be good. So put everything within your box, take a 3D, and then go to the sub 3D section. Start inversion mode. So all solids will disappear and all liquids will start appearing.
So what advantage do we get from that, madam?
You saw the tube, right?
Yeah. Yes.
You saw the entire block tube, hydrosalpinx filled.
Okay, so you're able to actually visualize the inside of the content of the tube also.
You have seen the entire tube. And another thing is, if there is a lot of fluid in the cavity, you are even able to see that fluid. Ki wo kahan par hai? What is the location? See, any fluid above the uterus is ascites. Any fluid below is not ascites. So a fluid in the cul-de-sac has a
Yes.
different meaning. A fluid on the top of the uterus has a different meaning. When you do inversion, you're able to see everything very clearly. Less chances of making a
Madam,
mistake.
suppose we have to report the fluid collection in the pouch of Douglas. How do you measure that volume of the fluid and give it to the clinician?
The rule remains the same. You measure it in 3 dimensions. So length, breadth, and width. Where you can see the correct pocket, that is where you measure in 3 dimensions. For any volume, that is the basic principle.
Yes, ma'am. And ma'am, Hycosi, have you started doing? Is it available?
That was my own case, see?
Yeah. So you got the Hycosi, ma'am? How do we procure Hycosi? That contrast?
I make my own contrast.
Acha, that xylocaine thing, ma'am. Oh, so someday we will have to ask Asha ma'am for the formula of making that frothy xylocaine.
It's not difficult, it's so easy and it works so beautifully. I showed you the images, right? You can see the entire tube lighting up and going, and you can take a Doppler. So it works beautifully.
So, ma'am, before you exit our WhatsApp group of PFSS 10, please give us the formula of making our indigenous Hycosi.
2 ml of xylocaine jelly and 10 ml of normal saline. That's it.
Okay. Okay. So I think everybody knows how to make this because this is also done in several workshops. But the important thing is if you learn something hands-on or practical in the workshop, you start implementing it. When you start implementing it in your OPD the next day or next week, that is the use of the conference. Conference is not simply going and sitting and chatting, having food and coming back.
See, conference is for meeting people. Webinars, Dr. Basab said, na, conferences are for that and webinars are for studying.
Yes, madam. So I think
Yes, ma'am.
Asha Jain, madam, and myself to some little extent, we are big fans of our office classrooms. We call this our office classrooms. We sit from the comfort of home. Many of you can switch off the video and take a cup of tea. In between, if the lecture you feel that you might watch later on, you can see a patient. You can even do a TVS quickly and come. So all our lectures of these esteemed faculties you will listen to Basir madam now are recorded on YouTube. We have a proper YouTube channel. Please subscribe to that channel and you can listen to hundreds of webinars absolutely at your leisure time. Thank you so much, Asha ma'am. That was a wonderful.
Thank you, Monica. Dr. Archana Basir ma'am is sitting here.
Yes,
I have great esteem for her if she would give her comments because she has been listening. So, ma'am, a few comments from you before I quieten and finish this session.
What can I say, Dr. Asha? It was an excellent hearing. I think I have already put my comment in chat box that it was amazing listening you and the amount of work and your quality of pictures of ultrasound was so good. It is very crisp, clear, and you made it look so simple. That's the beauty of it. So all those who have logged in will be able to learn. So that's what Monica is saying, that it's a classroom kind of a thing, that feeling. And the beautiful thing about this perfection series is that Monica and Randir give you enough time to explain. You're not rushing through the topic. Sometimes, like if you have to speak that's the all thing in 12 minutes or 15 minutes, you will not be able to do justice with the topic because there is a lot to be covered. So a really good amount of time, and you have comprehensively given everything what in an infertility scan one should see. And it is so amazing once you know something really within, like once you have a practice, it is on an auto mode. As you said that 2D 3D, I take a cut of the 3D and just keep it. So at your leisure time you can do it. You need not report at the same time, but you know that this was a problem, and because the infertility patient will come to you again for the follow up. Suppose if you had 3D thing and you found out something, you can mention it even later also, so that you can tell patient, well, I have taken this, I'm storing it, and then we'll see it. So that's the beauty of it. And I think you have done a really justice to the topic and beautiful. I really enjoyed your lecture.
Thank you, ma'am. Thank you so much. Coming from you, it means a lot.
It was indeed a very good lecture.
Asha ma'am, if you see the yeah. Madam, if you see the number of views on YouTube after a month or so, they will go in hundreds, they will reach 1000 plus, because this lecture will be very popular lecture, and I'm sure the next lecture is going to be equally exciting, because this is Baser Madam's forte. She is passionate about teaching, she is passionate about imaging and endometriosis.
Dr. Monica, just one point for Asha ma'am. Asha Jain ma'am, just I was thinking, because lot of litigation comes in the consumer forum on the reportings of the sonography and all, and you have perfectly said that please don't write anything normal. So you have to just write the dimensions and finding. So that's what a comment, ma'am. Thank you, ma'am.
Asha ma'am, it was a wonderful lecture, and images and the video which you showed now of Heiko C, it was marvelous, excellent. Thank you, Asha ma'am, for sharing.
So now, after really reveling in the lecture number 1, let us move to session 2, which promises to be equally exciting. And to start the proceedings, I ask Ankita Upadhyay, Dr. Ankita, to start the second session, please.
So after the first enlightening session by Dr. Asha ma'am, we now move to an equally important session. That is the next session for the day. That is stepwise approach to imaging in endometriosis. And I find pleasure to announce the speaker for the session is another esteemed faculty, Dr. Archana Baser madam. And to chair the session, I invite and I welcome Dr. Anu Agarwal ma'am, Dr. Praful Doshi sir, and Dr. Sudhir Adhikari sir. Can I have the CVs, please? Dr. Anu Agarwal is a director at Vansh Fertility and Test Tube Center, Ayushman Hospital, and Trauma Center, and Multi Speciality Hospital. She has been executive committee member of SR, and she has her fields of interest are minimally invasive gynecology and ART. She has academic contributions in form of various papers and published articles. We welcome you, ma'am. Dr. Praful Doshi, sir, is a distinguished professor in gynecology, and he has an experience of over 18 years, and he's the consultant at Blossom IVF Center and Me and Mummy IVF Center. And we welcome you, sir. Dr. Sudhir Adhikari has been the head of the department at various institutes at Manipur, North Bengal, and West Bengal. Sir has held various key positions, such as president of the Bengal Obstetric and Gynecological Society, and he has been an organizing chairperson for various conferences. Sir has led various academic roles as examiners of PG and UG curriculum. We welcome you, sir. I now request the chairpersons to do the honors and introduce Dr. Archana Baser, madam, and then we follow with her talk.
Hello, Dr. Praful Doshi here.
Yes, sir, please.
Can you hear me?
Yes, sir, you're audible.
Yes, sir, we can hear you, sir.
Yes, Dr. Randhir, Dr. Monica, I was listening to the last lecture. It was a wonderful lecture. And I like the statement that the conferences are for socializing and taking selfies, and webinars are for learning. Now, the next topic is by Dr. Archana Baser, and it's also a wonderful topic about imaging in endometriosis. Endometriosis, the way it is becoming rampant, and the imaging, we only know about chocolate cyst, but there are many nuances, very detailed things that has come up, and Dr. Archana Baser will enlighten us. She is a consultant at Akash Hospital, Indore, and she has held various important posts in Foxy, the vice president of Foxy in 2020. She has been organizing secretary of AICOG Indore in 2021, and she has been chairing organizing science committee chair in SAFO. So Dr. Archana Baser is properly entitled to give justice to this topic, and I give now stage to Dr. Archana Baser for a topic.
Thank you, Praful Bhai. Thank you so much for kind introduction, and thank you, chairpersons, Dr. Anu And may I be allowed to share my... Is my screen visible?
Yes, ma'am. Yes, ma'am.
So at the outset, let me thank Dr. Monica and Dr. Randir for giving me an opportunity in this perfection series so that we learn from each other. And that's really a good opportunity to learn in the comfort of our own consulting. So my topic today is stepwise diagnosis of endometriosis by ultrasound. As all of us know, as Praful Bhai also said, that endometriosis is becoming rampant. And I know it's a costly chronic disease. One day we were sitting, myself and couple of other colleagues, that why are we diagnosing endometriosis more and more? What is happening? So, I mean, dysmenorrhea, dyspareunia, dyschezia were all there before as well. But I think with the availability of the ultrasound and actually the good ultrasound, by knowing that we can diagnose endometriosis by ultrasound, we are trying to get perfection in diagnosing ultrasound endometriosis by ultrasound. We are picking up more and more endometriosis problems. So now we have a name to the problem which women were presenting to us with dysmenorrhea and all other dyspareunia and problems. And we know that nearly 10% of women of reproductive age group suffers from endometriosis. A little bit of facts and figures of endometriosis: about 1 in 10 women have endometriosis, and it is still alarming that it takes an average of 7 years for most women to get diagnosed with endometriosis, because it is often confused with irritable bowel syndrome. And mind it is the second most common gynecological disorder condition after the fibroids. And why it gets confused and missed in the diagnosis is, especially when it happens in the young girls, where you cannot do a transvaginal scan, and then you keep missing it out, endometriosis, because it is being labeled as simple cyst, or maybe sometimes the ultrasound itself is deferred, that oh well, she's a young woman, it is common to have dysmenorrhea in the young women. So I propose that when a young woman is coming to us with the pelvic pain, dysmenorrhea, please put in an ultrasound and see. So now what I'm going to cover is definition of endometriosis and adenomyosis in brief, ultrasound appearance of endometriosis within the pelvis, how to assess the pelvic mobility, which can also be easily learned, and what to look for during an endometriosis scan. So if you define endometriosis, it is the presence of endometrial-like tissue outside the uterus which induces a chronic inflammatory reaction. Endometriosis typically manifests itself in three ways. Either it can be endometriomas, which can easily be seen and diagnosed by ultrasound, adhesions, or endometriotic nodules, which can be deep or superficial. Now, what are the diagnostic modalities available to us? One is the ultrasound, contrast ultrasound, MRI, CT, endoscopy, biochemical screening, and histopathological definitive diagnosis. Will be focusing on ultrasound. So this is the most preferred modality for assessment of pelvic pathology. And the routes for doing ultrasound is either transvaginal, transabdominal, or transrectal. Now, why ultrasound? And we focus on ultrasound because once our Royal College president was asked which is the biggest invention or the of this century, and he said ultrasound, ultrasound, and ultrasound. Number one, because it is widely available, it is cost effective, and it can pick up ovarian lesions, endometrioma, and even deep invasive endometriosis, which I'll be taking you through in my talk. Now, scanning technique, I think already being talked about by Dr. Asha, that Jane, that it is like a transvaginal scan is something which we prefer, and follow it. You can do a transabdominal scan, which should be done ideally in any gynecological problem, follow it by transvaginal scan, and grayscale imaging can be improved by using HI, CRI when even subtle textural changes associated with endometriosis can be appreciated, and 3D volume ultrasound may be used to assess multi-organ involvement and adhesions. These are the surgical staging of endometriosis: stage 1 minimal, mild, and moderate disease, and severe disease of the. This is what, when we put a laparoscope, you can see, and this is the classification: minimal, mild, moderate, and severe. Whichever classification you use, ASRM classification and all, these are the things which you have to notice that what all structures are involved. Now, for the purpose of this lecture, I will be describing how to identify structures involved by endometriosis and showing corresponding laparoscopic images to improve the correlation. And this can be staged by any classification system you are comfortable with. So let's go step by step. Structures which can be involved in endometriosis are ovaries, uterosacral ligaments and POD, bowel, rectum, bladder, and uterus. So let's focus on ovarian endometrioma first. Endometriomas are probably the most commonly diagnosed form of endometriosis because of relative ease and accuracy of ultrasound diagnosis. Although their exact prevalence and incidence are not known, they have been reported in 17 to 44% of women with endometriosis, and the presence of ovarian endometriosis has been reported as a marker of deep endometriosis and multifocal deep vaginal, intestinal, and ureteric lesion. So, what are the features of ovarian endometrioma? Endometriomas are common, then can mimic other adnexal mass. They result from cyclical hemorrhage. The walls are thick and fibrotic. The contents consist of thick, dark, degenerated blood products, also known as a chocolate cyst. If unilateral, they are more likely to occur within the left ovary, and if they are bilateral in approximately 50% of cases, and usually regress substantially after menopause. So this is a typical endometrioma. I am sure this nobody would miss because it's a large endometrioma. So fluid levels, the hypoechoic layer will be dependent portion of the cyst like that, and it can have calcified foci within the cyst, that is called acoustic shadowing, and typically avascular. Whenever you see a large mass or large cystic structure, always put a color and you see, because you have a iota classification, another thing to rule out if there is any malignancy or changes in the adnexal mass which is there. And typical feature of endometrioma is it is avascular or low flow, and acoustic streaming can help discriminate it from mucinous and serous cystadenoma. This is again ovarian endometrioma, and this is like the 3D you can put, and you can see this is a bulge which can be seen in the ovary. And now what happens? Endometriosis may not always look the same. Mind it, and notice the cholesterol deposit in this clear looking cyst. I mean, if you are scanning it and if you are in a rushing clinic, you might report it as a simple cyst or a clear cyst, because the subtle changes which you are seeing here of a typical endometriosis are not that evident. So what you see here in a simple cyst, you will never see like a cholesterol deposit. So this is what you have to keep in mind. And then images of the same patient showing the ovaries stuck behind the uterus. So whenever you see a cystic structure in the pelvis and it doesn't have a clear ground glass appearance, or you are not very sure, you have to look at the other pelvic structures. Main thing is the uterus. What happens with the endometriosis, whenever you are taking a sagittal section of the uterus and transvaginal scan, you should not be seeing the ovary. Whenever you are taking a transverse section, then only ovaries should be seen. This is a sagittal section, and if you see ovaries in the sagittal section, you know that it is a stuck ovaries because it is behind the uterus. That's why it is staying here, and that should point towards that probably I am dealing with an endometriosis. Now, this is the laparoscopic view of the same patient. What you see, this is the uterus and this is the ovary which is stuck behind the uterus, and that is a typical endometriosis kissing ovaries, and you can see the increased vascularity, and this is again a sign of the endometriosis. Now, multiple ovarian endometriosis can be there in the same ovary. Either the same ovary has a single large endometrioma, or the ovary can have multiple ovarian endometriomas. That's why when you are putting laparoscopy, why it is important to really delineate or diagnose how many cysts are there, what you call it is a complete workup before you are putting in a scope. Otherwise, what will happen if you are putting in a laparoscope, you have decided to go for laparoscopy for various reasons. You see, this is ground glass appearance, and if you have not located that by ultrasound, the other cyst, you might leave it because it may not be that evident on laparoscopy, and patient will come back with the recurrence or may go to another your colleague and then they'll say, well, this was a incomplete removal. So this is a clip showing multiple endometriomas in the same ovary. It is important that this assessment is made prior to surgery to avoid any residual endometriosis. Otherwise, we always say, well, it has come back again, but no, it wasn't removed completely at the first hand only. So first surgery is the best surgery, and you have to see it out. And this is again an image showing multiple endometriomas in the same ovaries, and it is important that you assess it prior because this is a thick septum, and then you have to remove both the parts of the endometriosis. This is again an ovarian endometrioma with the cholesterol deposit, and there is a no vascularity around the endometrioma. And this is again on the laparoscopy. The previous picture we saw, this is on the laparoscopy. You see it completely stuck, and this is the adenomyotic uterus with the blister like, what you say, colorless endometriosis kind of a thing, and these are the ovaries which are stuck behind the uterus. So this was the picture, sonographic picture, so you knew that this is the one cyst which you have to remove, and this is the second one which you have to remove. So you are well aware, and you have already counseled the patient, and you know the extent of surgery you will be required to do. And the ovarian endometrioma, small endometriotic lesions are usually uniform and slightly hyperechoic than stroma, and these lesions usually do not change their ecostructure during different phase of menstrual cycle. Why it is important? Because sometimes ecostructure is not well seen, and that is said, well, it is a simple cyst, and come back again after 2 weeks or after the menstruation, and we see. But what happens with the ovarian endometrioma? It is not going to change with different phase of menstrual cycle, and you know that what was the size of the cyst when you did it premenstrually or during any other stage of the cycle, and when you did it post menstrual, the size remains the same. So these are again the various pictures of the endometrioma, typical ground glass appearance and large endometriomas. And when you see the endometriomas, it is already a stage 4 disease. So this is again the large endometrioma. When we put our scope in this patient, we saw this is the endometrioma which is lying by the side of the uterus, and this is again the endometrioma. This is the ovarian cyst, this endometriosis, which we will be doing surgery. Now, what are the differential diagnoses of endometrioma? Dermoid cyst, hemorrhagic cyst of ovary, serous cyst adenoma, and pseudocyst adenoma. So this is endometrioma, as we have seen in before also, and this is a dermoid cyst with a dermoid plug, and this is the most common sonographic feature of dermoid cyst, and this is a unilocular thin-walled cyst with fibrin stents or low-level echos and good through transmission. This is a hemorrhagic cyst of ovary, and this is a serous cyst adenoma, usually composed of unilocular or multilocular cyst filled with clear watery fluid, and this is a serous cyst adenoma. And this is a pseudocyst adenoma. This is a picture of pseudocyst adenoma uterus, and this is the sonographic picture, and you can see how close to our we at the diagnosis, and this is a tip septum which was seen here. So it is a large multilocular cyst containing fluid of various viscosity, and they rarely appears as unilocular cyst. Now, endometriosis rules. If you look at the endometriosis rules, single base discriminator between endometrioma and other cyst is ground glass echogenicity. Sensitivity is 73% and specificity is 94%. It is premenopausal status, 1 to 4 locules, and absence of papillation with detectable blood flow. Only are rarely sole finding, as I said before. They are the easiest to diagnose. However, by this stage, the endometriosis has already reached stage 4. Women with ovarian endometriomas have more pelvic and intestinal areas invaded by endometriosis compared to women without ovarian endometriomas. So it is important to identify other structures involved. So this is a typical picture of kissing ovaries. Both ovaries are joined behind the uterus in POD. Negative sliding sign, there's no movement of applying gentle pressure with transvaginal probe, and it's strongly associated with presence of endometriosis and indicates a severe form of disease. So this is a severe endometriosis. You can see kissing ovaries, adenomyotic uterus, and very densely adherent ovaries. Now let's look at the uterus in endometriosis. Due to involvement of the uterosacrals leading to adhesion, endometriosis tend to cause retroflexion and retroversion of uterus. This should alert us to the possibility of involvement of POD and need for further assessment. So uterus in endometriosis, look here. This is the uterus in endometriosis which is stuck behind, means because of the force of I mean the endometriosis, the chocolate material or the adhesion, whatever you say, it pulls the uterus towards it, and that gets stuck into the POD. And this is the altered version of uterus due to adhesion in POD. You look, what you call it's maybe a comma sign, though it's a feature of adenomyosis, but look at the cervix, and the uterus is retro version of the uterus happens in endometriosis because of the endometriomas. So this is the altered version. Now nodules are implants. Nodules vary in size from a few millimeter to few centimeter and are superficial or deep. Nodules may change appearance during the menstrual cycle. They become more swollen and congested during menses and develop internal hemorrhage. Only laparoscopy can detect superficial peritoneal implant. This is what a picture of endometriosis. What you see here is a big implant. That's why you can see in this picture. What is most important thing in an endometriosis scan is you have just seen the ovarian endometrioma, then you start working, or if a patient is presented to you with dysmenorrhea, dyspareunia, or during infertility, look carefully even for the implants. Once you learn to do an endometriosis scan, you will be able to see the nodules also. So look in this picture, the nodule in uterosacral. This is a uterus. What you see here is the behind is the uterosacral ligament, and you see the nodules in the uterus. The white line is denoting you the uterosacral, and there are the nodules. So you have to learn the complete, like how the sonoanatomy. Once you know sonoanatomy, you will be able to see what happens in the endometriosis. This is a moderate endometriosis. This is the hitching of the peritoneum at the around the uterosacral, and that can also be seen on the scan. And look at the ovaries. There is an increased neovascularization, which is again a sign of endometriosis. This is the uterosacral ligament, thickened uterosacral ligament, and which you can see on the scan the nodule. Now it's a very interesting and very topic, or you can say hot topic, deep invasive endometriosis. This is definition of a deep infiltration of infiltration of endometriotic nodule more than 5 millimeter. Its location can be sigmoid, uterosacral, rectovaginal, septum, vagina, or the bladder. So this is your dye, that is deep invasive endometriosis. Recto-uterine pouch, uterus, rectum, bladder, vesico-uterine pouch, anywhere you name, and you can find endometriosis anywhere. And this is a very interesting article in Fertility and Sterility, which says that clinical examination, ultrasonography, and magnetic resonance imaging and other techniques comparing for deep invasive endometriosis. And the bowel nodules. Can you pick up bowel nodules? Yes. Histological definition is presence of endometrial glands and stroma in the bowel reaching at least the muscularized propura. It involves anterior rectum, rectosigmoid junction, or sigmoid colon, typically hypoechoic or isoechoic solid masses with irregular outer margins, and they are tender on palpation. Look at this picture. This is a bladder nodule. So this is a bladder, urinary bladder. This is a patient who has a bladder endometriosis. This is small internal anechoic cystic areas seen in approximately 30% of the nodule. We knew this patient had a previous history of myomectomy done. Uterus fibroid removed, myomectomy, and then she presented to us with the severe pain while passing urine, and we scanned, and then we saw that she had a bladder endometriosis. This is again another view of the same patient. Look at the bladder endometriosis. So whenever this is another tip, whenever you are scanning for endometriosis or even a pelvic scan, transvaginal scan, do not completely empty the bladder. Have a partially filled bladder, so then you can pick up the bladder endometriosis. Or I have picked up even bladder carcinoma in one of my patient. She had a really vascular lesion in her bladder, and I was scanning her for infertility. Then we diagnosed bladder carcinoma. She was referred to the urologist, and then she got her further treatment, and then later on she conceived and has a baby now. So why it is important to diagnose bladder endometriosis? Because bladder endometriosis mimic recurrent cystitis with dysuria, urgency, frequency, and suprapubic pain and incontinence. Macroscopic hematuria is relatively rare in bladder endometriosis. It occurs in 1 to 4% of women, and diagnosis is often delayed or not considered at all. So why I'm saying the bladder endometriosis and ureteric endometriosis are important, because I have a very incidents where a young woman, 22-year, whom I only delivered presented to me with severe pelvic pain, and she had ultrasound done, a transabdominal ultrasound was done, but just around the pelvic area, and the detailing was not done. And she presented with severe pain. We did her scan, and I did a renal scan as well. And what we found that her kidney was non-functioning. We did all kinds of scan and did a lot of counseling, because once the kidney is non-functioning, it should not be kept in. So it is important before you are starting your treatment, or that what is happening. So her kidney, and we had to do, with the help of course, urologist did, and we had to remove her kidney. So why I brought this case here, that endometriosis is becoming very common. We are focusing only on endometriomas. We have to focus on the finer details, and always, whenever there is a deep invasive endometriosis, try and get ureter evaluated if there is a hydroureter. And if look at the ureter size here, how dilated the ureter is, and this should have been seen on the scan. Had it has been known that yes, she has an endometriosis, or patient should have gone in the time. And it is unfortunate that we had to do nephrectomy in her. So this is what is disheartening, that the problem is common, and we all have to be aware that how really to diagnose the problem. If we are not doing our own ultrasonography, at least we should ask, we should request the sonologist to look specifically, if it is a deep invasive endometriosis, what is happening to the ureter. It is very important. And this is the endometriosis in myomectomy scar, which is again a patient, 22-year-old, who had myomectomy done. And what we saw, she presented with severe pain, and this was endometriosis in the myomectomy scar. And this is again a picture of the endometriosis. And this is a very important thing which I want to highlight here, how to assess the ovarian mobility. So apply a pressure with transvaginal probe to assess whether ovary is fixed to the uterus medially or pelvic side walls laterally, and note any indication or the site of specific pain. So this is a picture of the sliding sign. How do you do the sliding sign? Put a little pressure, and then you see that everything will move together. We all are sat. So when they are moving sat, means the uterus and ovaries are all stuck together, and this is your deep invasive endometriosis. And it takes few minutes only, it doesn't take long to learn this, because you're doing your pelvic scan, you're seen an ovarian cyst, endometriosis, a small endometriosis. Just stay there for a couple of more minutes, put a pressure, and then you will be able to see that sliding sign is present or not present. So assess the POD mobility, use a slide pressure. Uterus, you should slide anterior to the rectum, and then use free hand over abdominal wall to assess movement of the uterine fundus. If no movement in either location, POD is recorded as obliterated. Look here. So sliding sign, a positive sliding sign indicates a POD free of adhesion, and it is seen in this clip here. Look, see here. There is a little bit of fluid here. If you can see, this is a small amount of fluid here, which is just a good sign that yes, the rectum is, the sliding over. There is a sliding thing. So there's a sliding sign present, and this is a picture where the bowel is adherent to uterus. Look here, everything is stuck. So there's an absent sliding sign. They're all going together. You can see the ovary is stuck at the top of the uterus, and the bowel is stuck behind. And they are not, uterus moves together as opposed to separately, what we see in the previous clip. So very easy to learn. All that, once you have to know what to do, once your mind knows, your eyes will be able to see. Then you can see even adenomyosis also in this uterus. So we were expecting the sliding sign to be absent in this case. And follow the black line, and that identifies the rectum. So look at this black line. This is the rectum. So this is all you can practice and learn. So this is again black line which identifies the rectum here. Now adhesions, flimsy adhesions have fluid entrapped within them, known as the flapping cell sign. So there's a question mark sign. Fundus of uterus is pulled by adhesion, and uterus is fixed. And you must have seen all of those who are doing scan. You might have seen sometimes this flappy thing in the POD, and these are the pseudocyst, or what you can say a flapping cell sign, because the fluid gets collected and because of the hitching of the peritoneum, and that is again one of the signs of the endometriosis. And this is the question mark sign. The fundus of uterus is pulled by adhesion and uterus is fixed. So this is additions in the POD. What I have shown you, the in the ultrasound, you can see the thickened uterosacral ligament. It's all densely adherent. Everything we went on and doing the detailed laparoscopy and all ediciolysis and removal of the nodules and ureterolysis and everything was done. This is again a thickened uterosacral in POD in the endometriosis, and these are the nodules which you can see on the ultrasound. So checklist in endometriosis is look for uterus mobility and adenomyosis, ovaries endometrioma and mobility, mobility of anterior compartment, mobility of posterior compartment, bladder bowel endometriosis, and most important thing I would like to emphasize is hydronephrosis. And you can have malignant transformation of endometrioma. I'm not going to detail of it. It's very rare, 0.3 to 0.8%, and typically in women over 85. And this is the simple rule of discriminating between benign and malignant cyst. There's an IOTA classification, unilocular, multilocular, ascites and all. MRI, should we be doing MRI? It is a non-invasive adjunctive test for diagnosis of endometriosis with ultrasound. What MRI does, it helps in assessing area which is inaccessible to laparoscopy. So sometimes if a deep invasive endometriosis you are operating, I mean you can get an MRI done to see the extent of the lesion, and only thing is it is operator dependent. And one thing is very important in international terminology for endometriosis, that is it is a paper by Matthew Leonardi et al. In which they have explained detailed analysis of endometriosis on ultrasound. So all those of you who are interested in learning international deep endometriosis analysis can refer to this paper, beautiful paper where everything they have explained in detail. So that is called IDA group, and that gives a very good insight into the endometriosis scanning. And take home message from my talk would be transvaginal ultrasound is accurate at assessing endometriomas. Severity of symptoms does not correlate with extent of disease. We know since our PG days, identifying an endometrioma likely that there is further site of pelvic endometriosis. Seeing the ovarian endometrioma, do not stop there, go further, look for other sites of pelvic endometriosis, kissing ovaries associated with extensive pelvic adhesion. Adenomyosis is usually underreported, and assessment of pelvic mobility can indicate adhesion. And to summarize imaging modality, with current improved high resolution scanning, it is now possible to diagnose most of endometriotic lesion, and addition of color Doppler helps in scoring and detecting endometriosis and differentiate it from malignancy. And transvaginal scan is accurate at assessing deep invasive endometriosis when performed by experienced operator, and we are regularly now doing deep assessment, because when you are practicing infertility and you know that women endometriosis is very common, so it is good, might as well, to learn to do a ultrasound and pick up the endometriosis. Deep and more appropriate referral to tertiary referral endometriosis center will ensure safer management. And thank you very much for patience listening, and I'll take this opportunity to ask for your help and support for my Foxy President candidate election year 2026. So thank you very much, for because every member matters, and I'm there with you, for you and by your side. Thanks a lot for patient listening.
Chairpersons, Dr. Praful sir, Anu.
Yeah, wonderful lecture, Rashna ma'am. And you told us very correctly, like before going to laparoscopy, we must properly check for number of endometriomas we have in the ovary so that we may not miss endometrioma. And
Exactly.
you told us beautifully, ma'am. Ma'am, just one thing I wanted to know. Sometimes we see papillary projections also in the endometrioma, na? So, how to differentiate this from the malignant conversion? Sometimes
Basic,
we see.
yeah, go on. Basically, there is a IOTA classification, Anu. You have to go through that, and there is a machines also have IOTA applications, so you can put that, or otherwise, I can go back in one slide. I did not read it because of the, I think the time. I thought I'm overrunning into the other speaker's time. So you have like benign, malignant features are there. It is unilocular, multilocular. What is the color around it? It's very important to put the color. Color will tell you that if there is a color around the thing means it's a malignant transformation is happening. And one more thing, good that you raised this question here. It is very important because sometimes that ovary may have endometrioma and carcinoma as well together, right? So that is a very important thing because I have given a talk and actually prepared it, that adnexal masses when they are there, sometimes a patient keeps coming to you for infertility. You are doing scan and you are every time reporting, looking at the only follicle, and you are missing out the other detailed features. And one of my own patient had an ovarian carcinoma because she did not follow up after 6 months of IVF cycle. So it is important that look at the ovary. Ovary is an organ where it can house a serous cyst adenoma, endometrioma, and malignancy and simple cyst all together. So it is very, very important that you differentiate it. She might have endometrioma and malignancy together or serous cyst adenoma together. So you have to know features of all the kinds of cysts which can happen in the ovary, and definitely always put the color.
Thank you, ma'am. And you told us very correctly. Always combine TVS with a good transabdominal ultrasound also, so that we may not miss any hydronephrosis or hydroureter, which we may miss during TVS.
Exactly.
Thank you, ma'am.
Dr. Sudhir Adhikari sir is there. Sir, would you like to have any comments after the talk on endometriosis by Dr. Archana Basir, ma'am? Sir, you're muted. Please unmute, sir. Sir, please unmute. Sir, please unmute. No, sir, we cannot hear you, Sudhir, sir.
Hi.
Hi, good evening, sir. Good evening,
Good
Amit,
evening.
sir.
Good evening. Good
Good evening,
evening.
Amit.
Hi.
Good evening, sir.
So,
Sir, we
sir, we
just
just
concluded.
concluded.
Congratulations, Amit.
Oh, thank you so much.
We just concluded.
And best wishes to you.
Thank you.
I have to reciprocate this.
Yes, sir. Yes, sir. So, so can we have President ISAR, Dr. Amit Patki's CV? Anmol, please can you show sir's CV? We extend a warm welcome to Dr. Professor Amit Patki sir amongst us, President ISAR, who has led the organization in a very unique and different way in the past 2 years. And the Perfection series revival in the form of Fertisphere and the 10 episodes we did are due to his persuasion and his encouragement that we could restart this program and do it with ISAR. And we are very proud of the fact that Dr. Amit Patki sir has always given us a free hand, always always guidance at any time we need his help, and also opportunity to interact in focus groups all over the country, like whether it is RPL or it is management classes or it is male infertility. He has given so many papers to us. Like every time I see the Facebook, I see some publication from Dr. Amit Patki sir, which encourages us to work towards research and better data presentation. So thank you, sir, for all the opportunity and for guiding us in ISAR. And sir, we would love to have words of blessings from you.
A very good evening to you all. And at the onset, I must congratulate Dr. Monica and Dr. Randir for such a fabulous trailblazing episodes in the last 2 years. Really, I think the every episode was very good. The topics were well chosen. The faculty was superlative, and every lecture had a take-home message. So I'm really happy that y'all really pulled out a very excellent webinar series. But I'm also a bit sad that this is going to be your last episode. But I think all good things have to come to an end, And I'm sure you will do something for the next 2 years in a different and maybe in a better format. So, best wishes to both of you and hearty congratulations. And I'm so happy to see my friend Dr. Archana. I'm sorry I missed your talk, but I'm sure I'll have many more opportunities to listen to you and your wisdom. So, thank you very much. And congratulations once again, Monica and Randir, and all my best wishes. And to all those who are listening, tomorrow is the last day for ISAR elections. I think you must put in your vote because you need very good people to lead the organization and make it very strong. So I would encourage and urge all those who have not voted to please vote. If there is any problem, you must contact Jyoti at the ISAR office or Dr. Madhuri Patil, who's always ever willing to help as election officer. So thank you very much, Monica, and I'm sure I'm going to see you on the other side in some time. Thank you.
Thank
Thank
you, sir.
you.
Thank you, sir.
Thank you, Dr. Amit Patki, sir. And it has been absolutely wonderful 2 years working under your guidance and leadership. We had a fantastic ISAR in Lucknow in 2025. And I'm sure a wonderfully great show, equally wonderful show, will be presented before us by Team Ahmedabad in the annual ISAR conference, where Sir would be handing over charge to the incoming president. But these 2 years have been truly memorable and, a sort of landmark for all of us. Garima is there, Manisha, Neelam, myself, Randir. We worked so hard in these 2 years and really worked like a family. So thank you so much, Amit sir. Thank you for your presence and your blessings. So now I request our third session to be started. And Dr. Payal, I think I just Garima is there. Dr. Garima will do the introductions and you can, deliver the vote of thanks, Dr. Payal, right? So Dr.
Okay.
Garima Sharma, please start session number 3.
Yeah. Uh, Thank you, Dr. Amit, once again for your words of blessings. They have always been very important for all of us. With this blessings, we move on to our session 3, which ever since its inception has been a burning issue, a less understood but the need of hour, which is a new ART Act overcoming challenges. And I would like to introduce our chairpersons for the same. May I have the CVs, please? Dr. Sashma Deshmukh, she's the Director, Central India Test Tube Baby Center, HOD OBGY Getwell Multi-Speciality Hospital and Research Center, past President of Nagpur OBGY Society 23-24, Chapter Secretary Vidarbh IFS 21 to 24, organized 3 national and 1 international hysteroscopy carnival, written more than 30 academic and non-academic books. I welcome you, madam. Can we have the next CV? Dr. Palak Gavri, she's the founder and director at Gavri Hospitals and IVF Center, Raipur. With 29 years of distinguished clinical experience, pioneer in infertility treatment in central India, leading a state-of-the-art IVF center providing ethical, evidence-based care since last 20 years. I welcome you, madam. Can I have the next CV? Dr. Lavanya Tyagi, infertility specialist, consultant at Javitri Hospital and Infertility Center, Head of Clinical Embryology at JHIC, Infertility Fellowship from NUH Singapore, and she's an ISAR certified embryologist, organizing co-secretary of ISPAT 22 Lucknow, member of organizing team of ISAR 25 Lucknow. Welcome you here. Over to the chairpersons to introduce our speaker, Dr. Randhir Singh.
Shall I start?
Yes, please.
Yeah, a very good evening to all. First of all, I must congratulate Dr. Monica Singh and Ranveer Singh for their fantastic perfection Sphere. Really, it has been a wonderful series, and I'm very happy to be a part of this wonderful series. So I have been listening Dr. Monica and Dr. Ranveer Singh since many years in ISAR, and really happy to be here to chair the session of Dr. Ranveer Singh. Can you just, yeah. Dr. Ranveer Singh is a director of and head of embryology, Bhopal Fertility Endoscopy Surrogacy Center and ERT Bank, organizing chairperson of 26th Annual ISAR Conference 2023 Bhopal, organizing secretary ISAR Embryology Bhopal 2018. as a managing committee member of ISAR 2024-26, member of Madhya Pradesh PCPNT board, member of Madhya Pradesh ART and Surrogacy board, founder and executive member of IC ISRAM India, then the Professor Allen Medical College and JK Hospital Bhopal, immediate past chairperson of Madhya Pradesh, multiple awards in ISAR, more than 50 papers and posters present in ISRI, then ASRM Aspire, and really is a very genius personality with us. I'm very happy, and these ART laws are they are never ending. We must learn each and every time because every time different laws are coming, and really many times we are getting confused. So I think Ranbir Singh is the best person to say regarding it. So your floor is yours. Welcome, sir.
Thank you, ma'am. Thank you, Shishma, ma'am. So I'll be taking half an hour journey for the ART Act because the ART Act always there is some problem in day-to-day findings. Just I was going through some got a WhatsApp from my colleague from Bihar that her wife is asking husband's embryo which has been preserved, but now the husband has died. So there are a lot of things, and that will be dealing in that. So without wasting time, now I'll come to the because whole ART Act has got, at December 21, there was first act came ART Act and then followed by the Surrogacy Act. So I'll touch the silent features and practical tips. As you know, it was a December end of 21 when the two act came. One was the ART Act and the second was the Surrogacy Act. And soon after a few months, the rules were formed. So according to definition, ART, see, because many in like AICUG Delhi also, many people, they asked me that whether we can do infertility practice or not. And also what the ART Act has done in the definition. So I'll define it as a legal angle. All techniques that attempt to obtain a pregnancy by handling the sperm or the oocyte outside the human body and transferring the embryo or gamete into the reproductive system of a woman. So that means it includes IUI, IVF, and ICSI. So normal gynae can do ovulation study. They can prescribe the infertility drugs, clomiphene, letrozole, or etc. They can prescribe PCOS patients, metformin, etc. But they cannot do IUI. That is the basic stage 1 of ART practice. Then who can do now IUI? So general gynae, you do the MS gynae or diploma gynae, get registered into your own state MCI, and you can start doing the practice. But in ART, that is a basic IUI, IVF or surrogacy, ART 1, 2, 3, I'll be going to the levels. You need a registration. So registration looks a little worry, like we do the MTP registration or the PCPNDT. But this act is a little different. You have to apply in the central website, and from there you have to download the application form and give it to your local body, local PCPNDT officer or local CMHO. They are in charge, and they will forward it to your state level. And from state confirmed, you will get the registration certificates. And the fees are ART1 is 50,000 and ART Bank is 50,000. Surrogacy is 2 lakhs for 3 years. ART2 is 2 lakhs for 5 years. So whether you do ART1, ART Bank or ART2, they are for 5 years. Only surrogacy, they have made it for 3 years. A few states, Madhya Pradesh was among the first states we started, and we had crossed 3 years. So our surrogacy registration expired in October, but we have given application and we have asked the rules from central government, and they have given a letter that till the rules of renewal are not formed for any, whether it's surrogacy, ART1, ART2 or ART Bank, they will be considered as a deem. So anybody whose registration is getting expired, don't be in panic. Be in touch with your local body and state board. As I am a state PCPNDT board of local also and the state ART board member, we have got a local WhatsApp group and we inform day to day to everyone. Definition as per ART Act. So minimum gynecologist, as we have told, is that you have to require as so should have a 50 oocyte experience pickup or 3 year of training as a registered ART center or with the DM fellowship or experience not less than 3 years of the reproductive medicine. So definitions are very important that I've described in the details. Now, what about the embryologist? Senior, we have prescribed one senior embryologist and one junior. For senior embryologist, they have to be PG in embryology on site. It cannot be on distant wise. You have to be on site or PhD holder, and they should be postgraduate degree and handling of human gametes and embryo. Medical graduate or MBBS graduate can be done, but they need an experience from the center, and they have to get registered at the ART2 clinics. Junior graduate in science, and they can act under the senior gynecologist and experience with the senior embryologist. Counseling. Now coming to the after act. As I told, who can counsel the couple? So can the gynecologist counsel them? Can the gynec start infertility treatment? Can any need a separate registration for this? So I have answered that. No, you have to get registered for ART practice, that is IUI. Before IUI, you can do the practice, no problem. Then who can age? In ART Act, age is very important. As we know in the PCPNDT, MTP, up to 12 weeks, 20 weeks. So here is the age group. So any women from 21 to 50 years of female can have ART practice patient, and man is up to 55 years. So 21 to 50 female, 21 to 55 is a male. And this is ages on the day of, for example, you're doing IUI or day of embryo transfer, not the ovum pickup. Even if you have cryopreserved the embryos, frozen the embryos or oocytes, every embryo transfer has to be finished above below that age limit. For example, if any patient is completing 50 years of female today only you can do the transfer, not tomorrow. Then can be friar, the same I have answered it, not allowed legally. You have to get it done before the age. Cancer patients. For the cancer patients, you can do, marriage is not required, and even the patient is suppose 19 year or 20 year, she has got a malignancy, so you can cryopreserve the oocytes, because malignancy is a separate a medical indication. For medical indication, age doesn't come into the picture. Can we provide for living couples? India doesn't allow. There are few countries in the world, but India doesn't allow the living in couples or even the gay couples. Can we split the oocyte between the husband and donor? Suppose we have got an IVF and the sperm count is hardly 1 million, and the patient want that, please I have got 10 oocytes, 5 oocytes you do with my husband's sperm and then 5 with the donor. So that is not allowed in the same cycle. So this is a gray areas, but we have discussed in the last in many conferences, in the workshops and in the panel discussions. But as the act says, the same cycle you cannot split. This gray area, it needs more discussion with the senior authorities. Then again, I got a message from my colleague from Bihar that they had preserved, they have got IVF done and the IVF patient failed, and in between the husband died, and the consent of preserving the embryos, the husband did not sign it. So actually, the product is of husband and wife. No one person is responsible. So a consent was taken by the two. So if the consent was not there by husband, is again a gray area. So I answered them that the family important is both the sides, parents, husband side and the wife side. They can decide with the help of an advocate and legal, because husband has not signed, but it is incomplete. To be safe, it is a very risky to go that. So always prior, we what the consent form says that if you sign that, in the death of anybody, my other partner is free to use the embryo or the product of conception. Donor sperm, again, is the same, 21 to 55 years. You cannot take that. And in this new act, earlier in ICMR guideline, one person can donate up to 15 persons. But in the ICMR guideline, that has not changed in the ART Act, one person to one. So you have to procure your semen donor from ART bank, and you can take from one patient to one. But in that, suppose you are stimulating a one IUI patients, and usually the ART bank gives you the two sample, because usually most of the people, gynec, they do two IUIs, one pre-rupture and post-rupture. So suppose if you have used only one, you can preserve that at the ART1 center, and you can use then the same till the patient becomes the pregnant. Then donor oocyte age limit. Here the donor oocyte limit is the couple age was 21 to 50 years. But in the egg donor, they have increased 21 to 23, and they have reduced from 50 to 35. This must have been done by our own researchers, because in this committee, there were many doctors from government sector, private sector. They must have told that after 35 years, the DNA fragmentation occurs. So I think aging of the oocyte made the quality. So 35 year is the upper age limit. And again, here questions they come from many colleagues of the across the India, that whether the oocyte donor has to be married, should have a living child. No. As per Act, only there is a the donor has to be Indian origin, and age limit between 23 to 35 years. Now, again, one thing. Suppose the donor is 35 year today. I have taken for oocyte donor, and I have preserved the embryo, and I'm transferring after 6 months or 1 year. So again, it looks a gray area, but as per my legal knowledge, as per my experience, I think the procurement of the age, that today the patient is 35 years, I can take out the oocyte. And if I have created the embryo, I can transfer later on. The commissioning couple has to be in the age frame of 21 to 50 years. Who need to procure a donor is the ART bank. It's duty of totally ART bank. And ART bank you can have in the same premises. You can have in the ART1, ART2 or separate. And it doesn't require much of the manpower. One doctor MBBS is sufficient with the minimum requirements of the like cryocans, centrifuge, microscopes and all, one sterile room. And if it's better, you can have a laminar flow and all. So you can have in the same campus, in the same hospital premises, but with a separate identity. What identity means? The owner should be separate, the license should be separate, everything, infrastructure, banking, everything should be separate. Then ART level 1 clinic, intrauterine insemination, procedures are carried out is a part of that. So ART1 is only IUI. And what are the requirement? A gynec equipment should have a microscope, because IUI you're doing. So you should have a microscope, centrifuge, refrigerator, and a perfect that you should have a cryo bank, also cryo tank, because if you are taking a semen sample from a bank, and if the bank is Sunday is not open, you can take the sample on the Saturday and put that, because though nobody is that. But ART1, you cannot have the ART bank facilities. You cannot do preserve the ART sample of for others or for IVF, because in ART1 you have got only one. So can ART1 do the ovarian stimulation? This is a very nice question, and it's often asked. ART1 can do only IUI if you want to do the stimulation. So suppose any ex-doctor want to do stimulation at her ART1. So she has to get a registered, or he has to get a registered herself to ART1 center. You can do the stimulation at your center and do the pickups and all clinical aspects, OT procedures in that. But your name has to be registered. And on the letterhead also, if you're giving a stimulation, on the letterhead should consider that Dr. X ART1 clinic is this, and he has registered for all this ART2 procedures in that center. That should be there in the letterhead. That will save you in the legal aspect. Cryopreservation, I have told you, ART2 you should have for your own. Then ART2 what? You can have a surgical gametes, because ART1 is only IUI. ART2, you can have a surgical retrieval, handling of the oocyte, fertilization of the oocyte, transfer of the embryo, carry out the storage of gamete. You can do the oocyte storage. You can do the cryopreservation of sperm, embryo. Provide that clinics. You can have ovarian tissue preservation also, because a lot of the cancer patients are coming nowadays. Then in ART2 clinic, as I have told, the gynec should have at least the experience of 50 OPUs, and they should have the practice of 3 years. When we started the act in 22, the exemption was given initially to all the IVF centers of India who are doing practice, because they considered that all the IVF centers before the 222, they were having 50 OPU experience, and all the embryologists who were working there, they were also allowed not to get the MSc or PG graduate in the clinical embryology courses. But after that, now the question comes whether that registered before the era of Act. Now, if he wants to leave the job and want to go to another place which has come after the Act, so that is again a gray area. PGT. So PGT is very important because nowadays, as a PCPNDT, and I was in AICOG Delhi, we were considering that in all the conferences of ISAR and all, we get stalls from the countries out of the India that they are doing the surrogacy, and they are saying that they might be doing the gender selection. So in India, the gender selection is totally illegal and it's a criminal offense as per the PCPNDT Act, which has come from the 1995 in the India last 30 years. So same imply here. So PGT you can do, but with a valid indication, medical indication, that a history of genetic disorder means a genetic diagnosis with one or both genetic parents have a known genetic abnormalities, and testing is performed on an embryo to determine it carries a genetic abnormality. PG testing means a technique used to identify the genetic defects. And nowadays we have got many chromosomal tests. So that is important, but indication is very important. Few people, they say that an increased maternal age, suppose a 39-year-old female with the AMH of less than 1 or zero point 0.5, you should screen. It's again a gray area. I think why to go in the troubles? You do one IVF cycle, and if you think you get an abortion or you get an abnormal baby, then you can go for that because you have to save yourself. Because we have seen in rural area, village, at the age of 42, 44, 45 years, they have a normal delivery, is also normal baby. So you have to prove yourself why you have done the PGT. Then transfer of gametes, now very important. Lot of centers open in every city, and the old centers, they close because survival of the fittest. Nowadays, too much competition, corporate hospital coming up. So if your embryos are preserved at one center, the new ART Act has given a permission to transfer your embryos from A center to B, either within city or within the India. Out of India, you can transfer, but it has to need that installation is that you have to go there. So that is very important. So I think that is very important. So that is very important. So I'll. So next topic is that. So I will come into the ART bank. So ART bank is very important part. That is, you can have, as I stated earlier, registered medical practitioner, anybody with the infrastructure. That is, you should have a little microscope, table, and laminar flow. That is minimum requirement. Then oocyte donor. So the donor has age limit, you have told 23 to 35, and you have to get a insurance of that, so that it depends. They have not mentioned, but 3 lakh is a minimum insurance, and then you should have at least 5 lakh to 10 lakhs of the death insurance. So that is a very important part, and that has to be taken by the ART bank. But I request all the ART centers, because it's the ART level 2 who give an application to supply the donor from the bank. So your duty is to see all the screening tests are normal, no HIV and tuberculosis and etc. infectious disease, plus the proper consent of insurance is there and with the documentation. Now coming to a surrogacy. A couple comes to a gynecologist for checkup of a surrogate mother. Is there any registration required for that? No. They can do it, there is no problem. Because any doctor can do the checkup of a surrogacy, because it's a right of a doctor to see any patient and the right of a patient to show to anybody. So coming to a little of a Surrogacy Act. Surrogacy Act is a very important act, and you have got a very penalty criminal offenses. You have got a very, I'll say it is like the mother-in-law for anybody. So I'll not use that word, but it's very, very risky. And if any loopholes you do in a surrogacy, you have to face a serious legal implications. So in ART Act, there are not that much punishments, but in Surrogacy Act, there are a lot of punishments. I'll not go in detail. So you have to choose a very one, that a couple comes to a gynecologist with a surrogate mother in the labor. Can a surrogate be delivered? Yes, you can get labor delivery also done by that. Duty of ART bank is sourcing the semen and the sourcing the oocyte. A bank shall obtain all necessary information in respect of a sperm or oocyte donor, including the name, Aadhaar number, address, because in the ART Act, they have told that only Indian origin can donate the eggs. And only Indian couple can have the facility to get the surrogacy. Age limits are fixed, as I have told you, 21 to 50 years for female, 21 to 55 years for the males. Single mother, yeah. A single mother is fit to have a ART practice. Anybody, any single lady who is 21 to 50 years can avail the IUR IVF. Then anybody who want to have a surrogacy. So single women cannot have a surrogacy. A widow, a single widow can go for a surrogacy, and otherwise same is for gents. A single parent, a single gent cannot have that one. Then can a oocyte donor or sperm known to be intending couple of single mother? Yes. Can OCI avail the surrogacy in India? Yes. Can OCI or PIO avail ART or donor ART in India? Yes. Can a foreigner avail ART services in India? Yes, but not the gamete donation of that. Then can a foreigners avail donor ART cycle? Yes, but they have to do all the recommendation of legal papers as you told. Can a foreign patient avail a gamete donation for their? Yes, but they have to do only the legal practice and they have got the medical visa. That is important for them. And now coming to a surrogacy act little. So surrogacy, as I've told you, it's a very serious act. You have to follow that. Earlier it was, we have that in the initially phase for surrogacy, both the sperm and oocyte has to be from commissioning couple. But a rule change came because it was very strict and patient could not get the facility, a medical indication where there, because there were many indications that the uterus was removed and the husband is azoospermia. So that was the human right, violation of a human right as the Indian constitution gives. So they have amended that anyone, either the male gamete or the female gamete should be available for the surrogacy. So now coming to the end of my part, that documentation is very important. So you should know what consent forms in the ART website, Indian, the where we get the registration in the surrogacy and ART website, you can get all these forms done. So for self IVF, I'll repeat, form 6, 9, 12. With the donor egg IVF, 6, 9, 13. So 6 and 9 are common, here 12 and 13. Then IVF with the donor sperm, again 6, 9 common, 12 and 15. Then IVF with donor embryo, 6, 9 again common everywhere. Here the 13 also is common as with the donor, 15 comes here. IVF with the self sperm is a 6 and 7. And IVF with the donor sperm, 6, 8 and 15. So 6 is general form for all IVF. Anybody know, can take this picture of this is very important slide. This you can get in the YouTube after the that. Then now surrogacy. MP was the first state to start the surrogacy because the certificate of essentiality and the eligibility has to be given by the local collector. But after that, before that, they have to get 5 certificates. That is certificate of medical indication by medical board, essentiality from the appropriate collector. Then eligibility criteria for surrogacy has to be given by district appropriate authority at ART surrogate center. Then certificate of medical and physiological fitness of a surrogate, registered obs-gynae practitioner, eligibility certificate of initiation of the couple, chairperson, district appropriate authority of that, then certification of recommendation from the state board. Then formats, I have told you certificate that I get in details. But as I told, this act has come in the hurry. So there are many gray areas. I'll not say the loop is, but gray areas. As they have modified from surrogacy, they had initially that both the gametes has to be there, they have modified. Now what are coming that in my Bhopal also many patients that they have lost their 2 children by accident and now the female is 51 years. They can have a normal child with egg donation, but now there is demand limits. So we have told them, you go and approach the court legal, because legal, so there are few gray areas where in these cases, they should relax the age limits. Then allostatic, yeah, it has to be allostatic because there is no paid surrogate mother required because it was a misuse we have seen in the past. Then storage of a gamete. You can store the gamete. Here they have not mentioned, but up to 10 years you can do. But after 10 years, suppose if there comes, you can again ask and request the ART surrogacy board at the center, and you can approach through your ART center state, and then approach that. You'll get the answer. So these are the email support and WhatsApp. So you can note down any query, you can directly email to them. They can respond very well, and we have got a very good system now. State, after this act, state board has been, central board was made first. Central board has completed their first term of 3 years. Now the new board has come with new members, and very few are of our own fraternity. And then they have got the state. Our fraternity, Dr. Neena Malhotra from Delhi AIMS and Dr. R.G. Patel from Ahmedabad are our friends, medical experts. And every state we have got almost everyone. Like I'm in the MP, so every state is there. And the few states like Uttar Pradesh, they are still in the formulation of the state board. But that's good. I think the new people will come, and you should be formal to them so that you can discuss your problems with them. So conclusion, just ART audit, consent forms, patient file, you should have a grievance cell because in the act it has mentioned. Then donors very perfect. You have to do only with the ART banks. Then register, you should maintain all the IUI register, IUI, OPU, FET, embryo transfers. Then PCPNDT is a very strict part. Without PCPNDT, you cannot open your ART center, whether it's ART 1 or 2. Then the proof of justification of general duties, eligibility of everybody, doctor's eligibility, embryologist eligibility, then age criteria, as I have told you, you have to stick. For that, local authority, they can come and ask the patient, your IVF patient was 49 years, just show me the Aadhaar card. So you should be able to, your documentation should be perfect. The proof of justification of general duties, that means discharge tickets should be follow that, date of OPU, how many embryos you have transferred, everything should be in crystal clear so that less legality. So change is inevitable, growth is optional. Thanks. I think I have tried to complete in time.
Thank you, Randir. That was a very precise and good information we got from you today. There was a question from my side.
Yes.
The thing is that if you choose a surrogate and she gets a kind of tuberculosis or something that the endometrium does not come up. Now that you want another surrogate, how do we go about it? Do we register right from the beginning or?
I'll tell you actually one slide I was not putting here. Recently, 1 year back, it was in the mid 24, one article has come from the central ART board, how to go for this surrogate certification. So they have mentioned that the surrogate selection, the commissioning couple comes to you. The commissioning couple can come to only that state where he is residing or he is officially posted or doing a job. So if you have chosen, the patient has chosen, suppose for example, Madhya Pradesh, my MP state, patient is showing to me, and I have I have seen the commissioning couple address, and either they are working here or they are domicile of MP. Then they will bring the surrogate. Surrogate can be from anywhere in the India, but their all certification has to be done here in Madhya Pradesh. After this, when this certificate of eligibility and essentiality is issued from the state board, it's valid only for 1 year. So 1 year is valid for that surrogate and that commissioning couple. If you want to change it, you have to go again with the ABC.
So right from the registration day, we have to count 1 year? The certificate of essentiality?
The certificate, suppose the certificate was issued today by the state board. So from today, it's 1 year.
Okay, thank you.
Again, here the gray area. Again,
no, so if
Dr.
the
Lavanya
surrogate...
here, sir, I had one question, sir. Sorry to interrupt.
Just answer this complete one gray area. Suppose your surrogate was there and the surrogate aborted after, suppose your certificate was issued today and during the procedure it took 6 months, and after 6 months the patient got pregnant and after 6 months she aborted. So almost 11 months over. So I think, see, these are all the gray areas. You can apply to the state board saying that my 1 year is going to get completed and I want to continue this surrogate. I think you'll get answer. Sorry, then you can ask next question.
Yes, thank you. Thank you so much, Randir.
Yeah, Dr. Lavanya, you're asking something?
Yes, sir. Sir, your slide on the oocyte donor, sir. Sir, you did not mention about the marital status. You said that no need for marriage, if I'm not wrong.
Yes, yes, yes.
But sir, I might be ill-informed, but I was under the impression that the woman who is supposed to donate her oocytes should have at least one living child of her own.
This is our see. So this is this is our thought. But as per Act,
Yes, sir.
only age is a factor, and all infectious disease and all you have to screen. That's all. Because same way I'm saying, same is for the sperm donor. He has not to be married. He has not to show the proof of a normal living child. So these are gray areas. So, but as the act for the donor oocyte or donor sperm is only age limit and
Yes, sir.
Indian domicile.
Okay. Yes, sir. I knew about the Indian domicile. I knew about the age, but I was under the impression that the rule says that she should have at least one living biological child.
No, no, Lavanya, the rule for having one living issue is applicable to surrogate. A surrogate should have one living issue at least.
Yes,
And for oocyte donor, the marital status or any sort of status of marital life or a single woman, nothing applies. No living issue is also required. What you are confusing is with surrogate.
Surrogate, yeah.
Surrogate.
Okay. And one more thing, sir.
Hmm.
We have a patient. We cannot call them a patient. There was a couple who had IVF at our hospital around 21 years back.
Okay.
And they had a son, and husband died quite many years back. Now, because of property dispute between the husband and the brothers of the husband, uh, the son approached us that I want to know the genetic testing and all, and I want to know who my biological sperm was or biological oocyte was. Do we have the liberty now that child is around 19 or 20 years old? Uh, Number one, we do not have the records anymore. It was because a long time back. And secondly, what if we had those records? Can we give it to the child if
See, it's a
we do
very
not have the
good question.
consent of the parents?
No, see, now the very important question because there are two areas like pre-independence, post-independence, 1947 and that. Now 22 and 20 before 20. See, earlier also in ICMR guideline, we have followed the HEFA, that is UK model of constitution of IVF regulations, was that HEFA says that a child has got a right when he becomes a normal. It means adult, 18 years. So
Yes,
when
sir.
child is 18 years, so you have to preserve. See, we always in my Madhya Pradesh Nursing Home Associations and IMA, everywhere I say, you have to preserve your PCPNDT and income tax papers at least 2 to 5 years. So 5 years minimum. So IVF, you have to, Lavanya, you have to preserve your papers till 18 years because you expect that child when becomes 18 years. Now coming before 2022, it was not an act. It was a guideline. So when you go into the court, you might get an excuse. But after 22, you cannot get an excuse. Now coming to your third part. See, whether the child was a donor sperm or self sperm, you maintain your records. See, oocyte collection, semen collection, donor or husband. You have own your own records, secret records. So I'll advise here on the platform is that anywhere, even the police comes and all, best way is answer that please go to the court. When a court gives you instruction, because I have got many, I have faced so many VIPs, ex-minister, ex-CM and all, preserve the embryos. One party says destroy it, other party says no. So it's always a court. So you ask them, please go to the court because court is there. For any crime, they go to Thana, they do the FIR. So it's better way. मैं मना नहीं कर रहा हूँ हमारे पास जो लीगल एडवाइजर है हमारे हॉस्पिटल के काउंसलर है वो ये बोल रहे हैं कि एक लॉक से आप एक इशू करा लीजिए फिर उसको भी ऐसा नहीं है आजकल बहुत वकील मिल गए कोई भी जज यू शुड हैव योर ओन लीगल सेल बिकॉज एनी क्योंकि एक पर्सनल उसका आइडिया है सपोज यू आर गिविंग एन हियर एनी इंफॉर्मेशन वेयर द काउंटर यू नो व्हाट इज एफआईआर किसी को चोट लगी फिर एक दूसरा काउंटर एफआईआर करता है तो व्हाट इज हियर आल्सो बी मेंटली प्रिपेयर्ड कि आपने दिया तो दूसरा बोलेगा क्यों दिया दिस इज इंपॉर्टेंट
Yes. So, for example, आई जस्ट वांटेड टू नो सर कि जो डॉक्टर पेशेंट कॉन्फिडेंशियलिटी होता है सर, जो जो एक इशू मतलब जो एक चाइल्ड इससे हुआ, तो आर वी सपोज टू गिव द डिटेल्स टू द चाइल्ड? अगर कमेंट जो एक्चुअल पेरेंट्स है, जैसे अब तो उस केस में सिर्फ मदर है, अगर मदर कहती है कि नहीं मेरे बच्चे को कुछ मत बताओ, तो
नहीं
शुड
तो
वी टेल
नहीं
द
नहीं
चाइल्ड?
नहीं नहीं नहीं, तो वो क्या बताया मैंने, आइडली आपको यू हैव टू गिव इट, बट बेस्ट है कम थ्रू द कोर्ट। बिकॉज हम क्यों बोले कि हम जैसे हु इज रणधीर सिंह, हु इज माई सेल्फ, हु इज लावण्या, लेट द कोर्ट से, लेट द स्टडी द एक्ट। एक्ट में लिखा होगा कि आपको पेपर देना है, बिकॉज आई वॉज डूइंग हियर, somebody died here as one question was Rajnikant's ART bill, they were asking that a patient died in the IVF OT, so you have to, the patient did not want to take the body, so you will inform to the police, so police will come and do the postmortem. So what I am saying, let the legalities go, because see, one thing is very important, as we have doing the patients, it's a that is confidentiality has to be, secrecy has to be maintained with the only couple, husband wife, not even a mother child and everything. But one law loophole, not loophole, I'll say, is a biological right of a child कि मेरा genes क्या है, because actually this made is what I usually go to the HEFA UK, this is for that कि उसको कुछ genetic diseases आएंगी from parents और donor, तो उसका treatment अपने doctors को बता सके, उसका use basically इसीलिए था, not for properties and all. So our job is that, see, in India also, even if you adopt a child, whether it's not of a biological child DNA of her father also, if I am fighting with my legal cases in my village and all, if whether your genes belong to your father or not, if you have got a legal child entered in your all Aadhaar cards and everywhere legal, they have got right for all properties. So आपके DNA testing से सिर्फ उसको property के right मिलेंगे ऐसा नहीं।
यस सर, दैट इज ट्रू। वो तो अब ऐसा भी है कि अगर फीमेल चाइल्ड है तो वो भी प्रॉपर्टी ले सकती है, बट किसी का मेंटालिटी है कि मेल को ही मिलेगा प्रॉपर्टी, तो यू कैन नॉट
Yes.
डू एनीथिंग अबाउट इट। ठीक है सर, थैंक यू सो मच, थैंक यू सो मच सर। Thank you, Monica ma'am. It was a wonderful webinar. I think Monica ma'am has some issues with her mic.
Sir, may I ask one
I'm
question?
sorry.
Sir, may I ask one
Both the
question?
audios, I had switched off my audio. So
Yes,
I
yes,
think
ma'am.
that brings us to the end of today's webinar.
Yes.
And concluding remarks can be given by Manisha. Dr. Manisha Bajpayee is there, my dear, very dear friend. And the vote of thanks can be delivered by Palak, Dr. Palak, who is my coordinator. So Manisha, please.
It was a wonderful webinar series,
Manisha,
and
you're
today,
muted. I think you're muted, Manisha.
am I
So,
audible?
no. Yeah, yeah.
I'm
Yeah. Sorry.
so
Yes,
very
you're
good
audible.
evening. Very good evening, everyone. It was a wonderful webinar series, and today this final episode was equally amazing. And it has followed the tradition of other 9 webinars which we have had in this span of 9 months. I believe it was a wonderful experience, and I think, ma'am, Dr. Palak is busy in her OPD.
Okay.
So, on behalf of all the organizing team, I extend my sincere and heartfelt gratitude to all our esteemed speaker for today's session, Dr. Asha Jain ma'am, Dr. Archana Baser ma'am, Dr. Radhir Singh sir, for their wonderful presentation, valuable insights, and academic excellence, which formed the cornerstone of this concluding webinar series. I would like also to express our deep appreciation to our respected chairpersons, Dr. Gurneet Singh, Dr. Monica Singh, Dr. Mitsu Doshi, Dr. Anu Agrawal, Dr. Prafull Doshi, Dr. Sudhir Adhikari, Dr. Shushma Deshmukh, Dr. Palak Gauri, and Dr. Lavanya Tyagi for their guidance, thoughtful moderation, and academic leadership, which has added depth and direction to each session. As we come to the final webinar of this knowledge sharing series, I take this opportunity to thank our coordinators, Dr. Payal, Dr. Purva, Dr. Ankita, for their dedication, meticulous planning, and constant support throughout the program. My sincere appreciation goes to my fellow co-conveners, Dr. Garima and Dr. Neelam, for their cooperation, teamwork, and unwavering support, which made this journey smooth and fulfilling. Now, I would like to place on record a special note of gratitude to our wonderful conveners, Dr. Monica Singh ma'am and Dr. Radhir Singh sir, whose who envisioned and conceptualized and executed this entire series with a remarkable clarity, commitment, and precision. With their presence and leadership, they have consistently supported academics, ethical practices, and right approaches in field of ART and remaining firmly rooted to the core values of our profession. Working under their leadership has been a wonderful learning experience for me as a co-convener, and I am truly grateful for the opportunity and the trust extended to me. It has been wonderful experience working with them and with the entire team. I also extend my sincere thanks to the backend and technical team of this for their tireless effort behind the scene, ensuring the seamless conduct of every session, especially BSc team. Finally, I thank all our participants and listeners to their enthusiastic participation and active engagement, which gave true meaning to this knowledge sharing initiative. With this, I would like Monica ma'am to finally convey the concluding word for this webinar series, and I'll convey a heartfelt thanks to each one of you.
Thank you, Manisha. Thank you, Manisha.
Thank you,
And
Manisha.
with
That
this,
was a
and just a minute, ma'am. I'll take one more minute. And at this final series, since we all are SRians and active members of SR, I would remind you all and request you all that tomorrow is the last day of voting, and our visionary conveners, Dr. Monica Singh ma'am and Dr. Randhir Singh sir, both are contesting for the post of MCM meeting. You have seen their constant hard work and their approach to their dedicated approach to the academics and rightful practices. So please do vote and support them. Thank you so much.
Thank you, Manisha. And managing committee elections are just side or byproduct of academics. I think yesterday I was talking to one of my patients who's also a gynecologist, and she has taken a break. She has conceived in the first IVF cycle, a poor ovarian response, and before her second IVF cycle, she left to do a fellowship in fetal medicine and now a fellowship in fetal interventions. Because yesterday I asked her, why are you giving so much of gap? She said, Madam, post MD, in MD I did not learn much, but knowledge is the true power. So this is it. I mean, I can see that power from Asha Jain ma'am. I can see that power when Manisha is deliberating or moderating a panel. I can see that power when Randhir is doing his ART talk. I can see the passion with which Dr. Basir ma'am is speaking on endometriosis. So there is so much of talent in each one of us, and everybody cannot be good at everything. And there has to be somebody who brings these brains together. So I have done exactly that. And I have given you the best speakers in the comfort of your home for forever recorded on social media and YouTube. So anytime you want to listen to Dr. Manish Bankar, or you want to listen to some wonderful international speakers Neelam had got us, or you want to listen to Professor Amit Patki, you just have to go to that particular webinar, click the link and see. That is because see, all said and done, traveling to conferences, coming back, it's so tiring that sometimes when you're after a long flight, you are sitting in the lecture hall and the speaker is speaking, by the time you are dozing off. So this is the importance of webinar, which I feel is here to stay. And thank you very much for a wonderful journey. This journey has been possible out of the whole team. The most hardest work has been done by the coordinators, the three girls. Also great inputs by my co-conveners. Manisha has handled solo webinars 3 to 4. Garima has done about a few webinars where she did give the inputs. Neelam was responsible for wonderful shows with the international speakers. So you people are real gems and very precious to us. And of course, Anmol. Anmol has, from the tech team, has done dry runs with me even on Sunday. Can you imagine? Sunday he is there leaving his family and his work and doing the dry run with me so that I can present the program on Monday. So this journey has been very enjoyable but so taxing that I need a break to rejuvenate, to think what has to be done, and probably talk to my sponsors also. So that is why we are, ending on a very, very happy note. The Perfection Sphere will be back later in 2026 in a fresh form, fresh platform with a new name and with a new show. Thank you very much. Thank you.
Thank
It
you,
was a
everyone. Thank you, everyone. And I think we'll continue this scientific because we started, as we told that Dr. Varsha Basti told that we are presenting our papers in SU and SRM. So this academy will continue on the ISAR, and we have got very young budding girls, Dr. Manisha, Dr. Garima, and Dr. others. So I think that will continue. Thank you. Thank you.
Wonderful working with you,
Thank
sir.
you very much to Team
Beyond.
BSV for providing the academic platform. This platform has been wonderful. This is the Perfection webinar is one of the few webinars where there have been no interruptions, no audio breaks, no hitch pitch, no disturbances. So we can actually have the confidence of recording it there and then. There is no pre-recording, it is recorded as it is. So thank you all very much. Thank you, Deepika. Thank you, studio team.
Thank you. Thank you.
Thank you, Anmol. And thank you, dear Manisha.
Thank you,
Till we meet.
Monica ma'am. Thank you, Randeep sir.
We meet
Monica ma'am, I just wanted to say that the dedication you have for the academics, ma'am, it really shines through.
Right.
Through it really shines through your knowledge and the effort that you put in each and every lecture of yours or each and every webinar that you've conducted, ma'am. Thank you so much, ma'am.
Definitely. I really wanted to add that apart from academics, this is a zeal and dedication, which I really want to learn and inculcate in me every time ma'am is there in spite of such a busy schedule. Hats off to you. It was wonderful. Wishing you all the best, ma'am. Bye-bye.
Thank you. Thank you so much. Thank you. Bye-bye.
Good night, ma'am. Good night, sir. Good night, everybody.
I love it. Good night. Bye, ma'am.